Systems of Care Summit. My name is Carol Boyer, and I'm your host for today's program, along with Teresa Heath from the Opioid Operational Command Center. And many of you know Teresa from her work as the Opioid Intervention Team Coordinator. And now she has an additional hat that she's wearing as their Director of Community Affairs. So congratulations, Teresa. Today's summit is a result of feedback that was received from many jurisdictions and ROSC co-chairs requesting more information on resources for implementation and strategies for improving their current ROSC stakeholder engagement and outreach efforts. And through some of those discussions, we found that there are several ROSC that are really doing some good work. So we wanted to bring everyone together to not only share resources and that good work, but to also gather more information from you as to what you need to build and sustain a recovery-oriented systems of care that's effective for those in your community who may be experiencing mental health disorders or substance use disorders. Initially, the summit was a hybrid event and was only open to local behavioral health directors and their ROSC co-chairs. But I gotta tell you, we received such an overwhelming response that we decided to move it to an all virtual event, so that we could open it up to anyone who not only wanted to hear more about ROSC, but who also wanted to hear from our A-list of speakers. So shortly, you'll hear from Robin Ricard, who is the Executive Director for the OOCC, or again, the Opioid Operational Command Center. And Robin will share more about what she and her team are doing and how they might be a resource for your county, for your city, and your ROSC. Next, we have Dr. Aliya Jones, Maryland's Deputy Secretary for the Behavioral Health Administration, who will present on the past, the present, and the future of ROSC, which is initially why this summit was set up. So then we will hear from three fantastic speakers. We have from the UK, Dr. David Best, who is a professor of criminology at the University of Derby. From Massachusetts, we have Dr. Hanar Hernandez from Hernandez Consulting. And from right here in Maryland, we have Jessica Hulsey, who is the founder and CEO of Addiction Policy Forum. All these folks are very familiar with and understand what it takes to build and sustain an effective and successful recovery-oriented system of care. Now, it's my great honor to read to you a special letter of welcome from William White. Many of you know that Bill is the visionary behind ROSC and is, unfortunately, he's unable to join us today, but he did want to share some thoughts. So Teresa, if we have that slide of Bill. And by the way, folks, you'll have access to this. We will send you this letter. I appreciate the opportunity to offer a word of welcome to those of you participating in this first Maryland ROSC Summit. My calls for the addiction treatment field to shift away from a model of acute biopsychosocial stabilization to a model of sustained recovery management, or RM, nested within a recovery-oriented system of care, ROSC, began in the late 1990s after I had worked in the field for more than 30 years. What spurred this effort was two realizations. First, I had become concerned that addiction treatment had become detached from the larger and more enduring process of addiction recovery and from the local communities we once served. Second, was my realization that we were repeatedly placing people with high addiction severity, complexity, and chronicity and low recovery capital into models of care that had little likelihood of generating sustainable recovery, and then blaming those individuals when such failures occurred. Recovery management and ROSC involve a radical redesign of addiction treatment and related recovery support services whose success or failure will determine the future of addiction treatment and recovery in the United States. They represent efforts to shift the center of our field from a focus on addiction pathology and clinical intervention to the prevalence, pathways, processes, and outcomes of long-term recovery for individuals, families, and communities. They represent efforts to build the physical, psychological, and cultural space in which recovery can flourish in every community. I wish each of you and your programs Godspeed on your journey into this future of addiction recovery. And that letter is signed by Bill White. It couldn't be more perfect, especially given that this year's theme for National Recovery Month is recovery is for everyone. It's for every person. It's for every family. It's for every community. So with that said, let's get started. Teresa, take it away. Teresa?
Thank you.
Okay,
Thank you, Carol.
Okay.
Welcome, everyone. We're so glad you're joining us today for what is sure to be an informative and engaging event. I'll start by going through a few housekeeping items. If you haven't already, you can introduce yourself in the chat box with your name, organization, or agency, and the reason for attending the event today. We will be muting all microphones and turning off cameras during the presentations. We have a packed agenda and a lot of wonderful speakers today, so we ask that you put any questions that you have in the chat. You can put them in there at any time throughout the day. And if we're not able to answer all of the questions when the time comes, we will address them in the follow-up email after the event. Additionally, as Carol mentioned, the event will be recorded, and we will make that recording available following the event as well. Finally, it's my pleasure to introduce Robin Ricard, Executive Director of the Opioid Operational Command Center. Robin was recently appointed Executive Director after serving as our Deputy Director and Chief of Staff for 2 years. Prior to that, she was an Assistant State's Attorney for Anne Arundel County, where she prosecuted hundreds of felony drug cases. In 2008, she became involved with drug court and oversaw both the circuit and district drug courts for the state's attorney's office. It was during that time that she became passionate about saving the lives of individuals with substance use disorder who were involved in the criminal justice system. So Robin, I will pass it over to you now.
Good morning, everyone, and thank you for that introduction, Teresa, and thank you very much, Carol, for all your hard work organizing this event today. It's always a pleasure working with you, and I appreciate your tremendous enthusiasm for supporting people in recovery. Carol and I go way back several years when I was involved with drug court, and we first met when I was involved with the Anne Arundel County ROSC. Years and years ago. So I really, really appreciate you and everything that you're doing for the state of Maryland. Thank you also to all the speakers today and everyone joining us. It's wonderful that so many of you are able to be here, and it is our sincere hope that today will help inspire more collaboration across the state. Promoting recovery support resources is a central component of Maryland's strategy to address the opioid crisis. So we applaud all the work that you do. And for those of you who may not be very familiar with the Opioid Operational Command Center, the OOCC is Maryland's primary interagency coordinating body for the state's efforts in response to the opioid crisis. In my presentation today, I'm going to quickly go over what we are, who we are, what we do, and I'll also review some of the most recent opioid overdose related statistics that we have available and some of the efforts that we're engaging in to address the opioid mortality across the state. So the OOCC was created back in 2017 when Governor Hogan declared a state of emergency in response to the opioid crisis. The executive order that established the OOCC outlines our mandate, which is to prepare the state's interagency coordination plan, which is our strategic plan for addressing the opioid crisis. We coordinate the efforts of state agencies and Maryland local jurisdictions, identify gaps in local resources, coordinating state resources to fill those gaps and disseminate best practices. In creating the OOCC, the governor laid out three major policy priorities to guide us in our work. These are prevention and education, enforcement and public safety, and treatment and recovery. The coordination plan, which we update on an annual basis, outlines key strategies and tactics in each of these areas. And using the plan as our guide, the OOCC works with all state agencies engaged in opioid-related programming so that we can facilitate collaboration to the greatest extent possible. And I know a lot of people on the line today have been involved with giving input in the strategic plan. We also work with opioid intervention teams in each of Maryland's 24 local jurisdictions. Opioid intervention teams, or OITs, are multi-agency coordinating bodies that seek to enhance collaboration at the local level. OITs are chaired by the local health officer and emergency manager and have representatives from other agencies and community or faith-based organizations. And some of them you can see on this slide. The OOCC meets annually with each of the OITs to help share information, best practices, and to learn about the unique challenges in each jurisdiction. And for more information about this work, you can contact our new Director of Community Affairs and the OIT coordinator, Teresa Heath, who was just on. In the next portion of the presentation, I just want to really quick walk you through some of the most recent opioid-related overdose statistics that we have available. This will help you give an idea about the current scale of the problem that we're facing, and everything shown on these slides can be found in our recent report for our first quarter of 2021, which can be found on our website before it's too late.maryland.gov. So in the first quarter of 2021, there were 682 fatal overdoses in Maryland involving all types of drugs and alcohol. This represents a 5.7% increase from the first quarter of 2020. So sadly, it does appear that the effects of COVID-19 continued to complicate the opioid crisis in the first 3 months of the year. In 2019, we actually went down, and we were excited that maybe we were going to continue that way, and unfortunately COVID came about. So for context, opioid-related deaths increased by nearly 18% last year in Maryland and nearly 30% nationwide. 612 fatal overdoses involved opioids in the first quarter. Next slide. This represents a 6.3% increase from the first quarter of 2020. Opioids were involved in 89.7% of all fatal overdoses. Looking at individual opioids by type, we can see that fentanyl continues to be the primary driver. No surprise there, right, to everybody. Fentanyl was involved in 92.2% of all opioid-related deaths, or 82.7% of all fatal overdoses. Fentanyl-related deaths rose by 5.2% in the first quarter, and heroin fell sharply, decreasing by 27.7% compared to the same time last year, which is a continuation of a trend of rapidly falling heroin deaths that goes back to 2017. Prescription opioids increased by 37.4%. And switching gears, the next two slides, we're going to look at non-fatal overdoses in Maryland in the first quarter. As you can see here, there were 2,397 hospital emergency department visits for opioid overdoses from January to March of 2021. This is a 17.8% increase from the first quarter of 2020. And it's important to note that ED visits were down for all cases in the first quarter of 2020 due to the pandemic. Next up, looking at EMS Naloxone Administrations, there were 2,354 total naloxone administrations by EMS personnel in the first quarter, representing a 4.6% increase from the same time in 2020. The largest monthly increase occurred in March, which saw 13.8% more naloxone administrations compared to March of last year. And as the numbers show, the last year and a half has been difficult for people living with substance use disorder. To help meet the challenges, the Hogan Rutherford administration recently launched a new campaign called Maryland SOS, or Maryland Stop Overdose Strategy. Through Maryland SOS, we're leveraging new and existing resources to support a wide variety of prevention, enforcement, and treatment initiatives. The campaign also involves a series of regional town halls because we want to hear directly from the community how the opioid crisis has impacted their lives. The town halls are also an opportunity for us to discuss the Opioid Restitution Fund, or the ORF. The ORF was established in 2019 to manage all money that Maryland receives from legal settlements with opioid manufacturers and distributors. Maryland already was awarded $12 million earlier, and much more is anticipated in the years to come. It's $10 million right now, and in the next 4 years, we'll get $500,000 for the next 4 years. Maryland SOS is our way of considering the needs of all communities when distributing the funds. There are restrictions about how the funds can be used, and we want to educate everyone about what they can expect to see in the future. The legislation that established the ORF, or Opioid Restitution Fund, specifies that the funds can only be used for a variety of programs, which you can see on this list on the slide here. I'm not going to read all of them to you, but the most critical areas include treatment and recovery, peer programs, screening, brief intervention, and referral to treatment, or SBIRT, increasing access to medications used to treat opioid use disorders such as buprenorphine and methadone, mobile crisis service, school education programs, and many of these programs are already being implemented at the local level across Maryland, and we're very excited about the opportunity to expand them wherever possible. We held our first town hall on August 26th at the Allegheny College of Maryland in Cumberland, and we received tremendous amount of good feedback. Our next town hall is scheduled for October 20th at the Salisbury University in Wicomico County. So if you live on the Eastern Shore, we sincerely hope that you can join us for that. We also ask that you help us spread the word. We want as much participation as we possibly can get so that we can share all the details of them, and we can share all the details of the meetings with everyone. And if we would really appreciate it if you could do the same. We'll be distributing a flyer for the event with more information following the summit, and we hope to see everyone there. We're also currently working on scheduling town halls in other regions, including one for Baltimore City, which we're hoping to be our next location. So please stay tuned for additional updates from our office, and we're hoping that the next quarterly report will be released very soon. So in closing, again, I just want to thank everybody for being here today. The work that you're doing is so important, and we applaud all that you do, and we appreciate your partnership. And next up in today's program, you'll hear from my esteemed colleague. It is an honor to introduce Dr. Aliya Jones, Deputy Secretary for Behavioral Health at the Maryland Department of Health. Dr. Jones is recognized statewide for her expertise in leadership as an addiction specialist. She's been leading the Behavioral Health Administration, or BHA, since January of last year. Prior to this role, she served as Chief of Psychiatry and Chair of the Behavioral Health for 7 years at Bon Secours Hospital in Baltimore. And with that, I will turn it over to you, Dr. Jones.
Dr. Jones, are you muted, or? I don't think we can.
Let me start my video and unmute
There you go.
first.
Thank you.
I had the order a little bit backwards. Okay, so now you can see my screen. Let me put this in the right. Okay, can you see my screen now? Are we good?
All good.
Yes.
Okay, wonderful. Thank you. So good morning, everyone, and it's certainly good to be with you. I bring you greetings on behalf of your Behavioral Health Administration, and I'm happy to be here to celebrate one of the final celebrations that we have in this month of this is September, which is the end of National Recovery Month. So for those of you who are in recovery, I just want to say and extend congratulations to you for all of the hard work that you have done in the past, present, and in the years to come. So this year's theme for National Recovery Month is every person, every family, recovery for every person, every family, and every community. And we know that if we can continue to develop the systems that make it easy for people to access care and continue to combat the stigma that keeps people out of care, then indeed we can make recovery possible for all, and help to restore our individuals and then also to restore communities. And so Recovery Month is really exciting because it's so many reminders that recovery is possible. And particularly, we need to be reminded when we're faced with the ugliness that is the existence of living with a severe addiction or a severe behavioral health condition. So I've been asked to talk about the recovery-oriented system of care, its past, its present, and its future. And I believe I'm pretty much speaking to the choir when it comes to ROSC. You all have been operating in this space for many years. And in the state of Maryland, and I think in a lot of places, when people first started looking at ROSC or the concept of ROSC, it came out of the framework of addictions and looking at the space in the field of addictions. However, it's become more integrated into behavioral health as a whole, and looking not only at having recovery-oriented systems of care for those who have substance use disorders, but for those who have mental health disorders as well. So what exactly is a ROSC? A ROSC is a coordinated network of community-based services and supports that's person-centered and builds on the strengths and resiliencies of individuals, families, and communities to achieve abstinence and improved health, wellness, and quality of life for those with or at risk of alcohol or drug problems. And this was, again, SAMHSA's original definition back in 2010. I haven't seen an updated definition, but I would say that what the update would be is that we're not only talking about alcohol and drug problems anymore, but we're talking about all behavioral health conditions. And the date of 2010, I think, is significant because it references, this is the definition that they arrived to after about 10 years of looking into and working on and helping states develop recovery-oriented systems of care. What does that mean? Which is an outgrowth, I'm sure, of the work that began in the late 1990s, and that was referenced by the letter that was read. So what are the elements of a recovery-oriented system of care? And what are the elements of this system that are different perhaps from other systems or systems of healthcare? Well, one thing I think that we all recognize is the importance of family and other ally involvement, because people recover in communities. We don't recover alone. That you have services across the lifespan, which speaks to the need for continuity of services, and that when someone is in a recovered state, it does not mean that they don't need supports or resources to maintain in a recovered state. Just like we need for any medical condition, we need supports as we continue to walk through any health condition. One of the things that does make it different is that it's anchored in the community, and the community being outside of the general medical establishment, because again, people don't live within the medical establishment, they live in communities. And so you have to make sure that the access and the supports and services are available through the community. There's a continuity of care as opposed to focusing on treating a substance use or mental health condition in an episodic manner, which is the traditional way that Western medicine manages healthcare. But I think we're all looking and pivoting towards the fact that you really do have to look at someone across their health span, as opposed to just when people are acutely ill, and provide resources accordingly. And of course, as we all know, that there's a commitment to peer recovery support services and a recovery-oriented system of care. Peers are critical throughout all phases of a person's recovery process, from helping people to to be inspired enough to know that they can take that first step towards putting down a substance if they're using a substance, or towards accessing behavioral health, mental health services if they are suffering from behavioral health conditions, or if they're living with behavioral health conditions, to giving people encouragement throughout the course of active treatment, connecting them to resources that address other phases of their treatment beyond the acute medical management of the condition if a medical approach is taken. And then also lastly, just helping to ensure that people stay connected and resourced appropriately in the community when the acute phase of their condition has been resolved. It involves, importantly, an integration of services as opposed to our traditional siloed ways of doing things. People do have to work better. We have to work together. We work better when we work together. But this system recognizes and respects the importance of integrated services, having a system-wide approach, and again, having that ongoing monitoring and outreach. So in Maryland, beginning in 2008, we started having, this was, well, I was in Maryland at the time. However, I wasn't a part of the state at that time. That's when the state started looking at recovery-oriented system of care and looking at the state's role in supporting a recovery-oriented system of care by looking at policies and procedures and the way that we operated, and making sure that we were walking in a direction that would lead us towards a recovery-oriented system of care. Developed a steering committee that developed numerous goals that are all before you that would help to lead the state in the proper direction. And part of that work involved obviously engaging stakeholders, training people in the recovery-oriented system of care model, and looking at evaluating the services that were being provided, because we know that evaluation is critical in order to maintain funding for particular initiatives. So what was accomplished? The awareness of ROSC was raised. People became aware of what ROSC was and the importance of pivoting towards a more continuous-based, a continual care model that engaged communities and peers. It established the peer recovery workforce in the state of Maryland, which was critical then and continues to be very, very important for us as we continue to move forward. I think it's important, I just threw in here that the ROSC framework it's not a simple framework. It's a very comprehensive framework. And when I look at the care and the services that the Behavioral Health Administration supports, we really try to ensure that we are supporting a full continuum of care. We're continually looking to how we can better integrate services. We're doing a lot of partnering now with the Maryland PCP program. And why is that important? It's important because people with behavioral health conditions tend to use their primary care services more than other individuals. And so it's a great opportunity for outreach and to engage people in services. But then once a condition is recognized, you have to make sure that people know how to get connected to services and that those services exist. And so we continue to try to frame out and develop resources in the community and helping to improve the ability of providers to connect people to those resources. But then also we have to ensure that people in the community know how to connect one another and to resources and access those reasonable and important resources. And overall, one of the things that we're greatly focusing on more and more is improving our outcomes and measuring the quality of the care that's being provided in whatever type of setting it's being provided. So is the initiative being effective? Are people getting connected? Are people utilizing the resource that's available? So the future of ROSC, I think is a very, very good question. I would say there is a future. I mean, ROSC is the present, ROSC is the future. There are questions around additional funding for ROSC. There's new conversations at the federal level, which I'm sure many of you are aware of, about whether we should have some of our state block grant dollars set aside specifically for recovery-oriented services. I don't know what impact that's going to have for the state of Maryland because we already spend probably close to 10 million or more. And I'm sure, of course, there's always more that could be spent. But if there is a federal mandate, I'm not sure whether that means it's going to be above what we're currently spending or a certain percentage of what the feds would expect us to spend. I would say that if it's not more than if they don't tell us to spend more than what we're already spending, it's likely that what we're already spending is going to fall within the expectations of what is expected to be provided for recovery-oriented services. So waiting to see how that's going to how that's going to play out. I think we should all know something more about that within the next year. Looking at enhanced community partnerships, and again, I mentioned working and partnering more with primary care providers, and again, as continually looking to identify barriers and promote access in the general community, collecting more outcomes data, and that's going to require enhancing our technology to establish the quality of the services that are being delivered, and therefore where improvements are needed so that we can optimize all different types of services that are being provided and supported in the community. And then we're right now having conversations about how can BHA be more of a partner with regards to ROSC in the community. We are already committed to a recovery-oriented system of care. We have a recovery-oriented system of care. However, the work that began in the early 2000s still needs to, it was not completed. So there was funding, my understanding, funding that was at the state level that went away because there were other priorities. And so hopefully with the new funding that's coming down, or potential mandate for spend will give us the resources that we need to reestablish the internal infrastructure that's needed to pick up the work where we left off probably, I believe about 10 years ago, a little less. And so with that, I think I did not run out of time, which I have a tendency to do. I hope that you all enjoy the rest of your day. Thank you for joining. Thank you, Carol, for the invitation, and be very well, and happy National Recovery.
Oh, Dr. Jones, thank you so much. That's what we needed to hear, right? That's what we were looking for. So thank you so much. We know you had to jump off the call. You have other commitments. So thank you again. At this time, if you haven't already done so, please make sure to go to the chat box and add in your name, your organization, your agency. If you're not affiliated with an agency or an organization, put in what county or city you're from, why you're here today. What initially drove you to this event, and what you'd like to get out of it, and any questions that you might have. We probably won't get to all those questions today, right? But we're going to capture the chat, and I promise you we will follow up, because so many of you have been calling and saying we want to do this and we want to do that and so on and so forth. So if we have it all there documented, we can follow up with you. So while you're doing that, I'd like to ask Tom Carl, the founder and CEO of R1 Recovery, to join us to introduce our keynote speaker. And I just want to give a personal thanks to Tom, because I had heard of Dr. Best and his work, but it wasn't until Tom suggested that I have him as a keynote that I had the great pleasure of getting to know Dr. Best. So listen, folks, you're in for a real treat. So Tom, take it away.
Thanks, Carol. Hi, everybody. I'm Tom Carl. I'm actually the founder, as Carol said, I'm the founder and CEO of R1 Learning. We're actually headquarters not too far from Maryland. We're actually in Arlington, Virginia, just outside of the nation's capital, so we're close by. And I'm here in my role today. I have two roles. I have a role of I'm one of the sponsors for the event, and then I'm also going to do an introduction of our keynote, Dr. Best. But before I start, I do want to thank. First, I want to just start by thanking Carol. I think a lot of you may know her. I've gotten to know her along my R1 learning path, and just as you probably all know about her. She works tirelessly in the field. She's passionate about people in recovery. She's passionate about this industry and this field. She's worked tirelessly to put this thing together. It started in person, it started hybrid, and now here we are today. So I just want to really hats off to Carol for her energy and her passion to bring us together. Also want to, as a person, not only stepping out of my role as founder of R1, I'm also in recovery. I come out of 25 years in corporate education, working with mostly Fortune 500 companies, Fortune 1000 companies, and government institutions around the nation, around the world. But I'm in recovery, and with that, it brings me a lot of gratitude for your work. I've been in the behavioral health field for about 3 years now, working with R1 Learn. I'll share a little bit about that, but thank you all. I just hoping you'll just take a moment today to just think about, that you bring contribution, you bring your energy, you bring your passion to your work every day, and it matters. I know it matters to me, so thank you. But it matters is sometimes we get into our work and it becomes work. But at the end of the day, the numbers that came up earlier on the PowerPoints, they're real, and so I just want to thank you all for your hard work. R1 Learning we're an educational company. We're focused at oh, thank you, Carol, for you can see it on the screen. We're focused at really a couple of things. We're focused at really engaging people in their recovery. People, we talk about meeting people in recovery. What R1's about is we want to meet them in their learning. We want to meet them how they process information. So we've been building curriculum around behavioral health, around specifically substance use disorder, and because of, I'll get to this in a moment, around recovery capital, and also life skills. How do you help people with career interests, and how do you help them think about their values, and how do you think about their financial stability? So we have in our curriculum topics around those kinds of things to help people throughout the whole curriculum of recovery. And so we're an education company. We're focused, we're doing a lot of work around training, and I'll use the word practitioners, people practicing in the field. So we work with clinicians, we work with provider organizations, counselors, social workers. We're working with people in drug courts and in prison systems and jails, treatment providers, high schools, and we're working and doing training with psych techs, peer support providers. If you're touching people with behavioral health and substance use, hopefully you're going to meet R1 Learning along your path. And then the last thing, we're bringing our system online. If you don't know about us, I meant to tell you this earlier. If you're on the screen here, go to www.r1learning.com and you'll learn a little bit about us. But what we're focused at are finding all the wonderful behavioral health best practice, evidence-based topics, and bringing them into an educational system so that people can actually, really see themselves and where they are in their treatment, in their recovery. And so we're focused at that. One of the things, and I'll segue to my introduction of Dr. Best. So as we came in the field, and I showed up at Turk. We showed up at Turk 3 years ago, in 2018. We showed up at the Turk conference. Although we're working nationally, and we're working in most of the states in this country right now, we started here locally, and we went out and found all the evidence-based practice models, went and found all the thought leaders, because we knew we were going to have to be grounded in that in order to be effective. One of the concepts that I found early on, I was looking for key concepts. And one of the ones I was looking for was one around what's going to be the umbrella for the R1 Learning system. What's going to be a system, kind of a systems view of this space. And I landed very quickly on recovery capital. And through that, I reached out to Bill White. He probably doesn't remember me, but I reached out to him and I said, I just want to learn as much as I can. What should I do, Bill? And he stopped me in my tracks. He said, you know what you need to do, Tom? You need to go find Dr. David Best and go talk to him, because he's really leading the charge around the world right now with his research and what he's doing with his PhD students around the world. He's in Australia, New Zealand, Canada, obviously Europe, and he's really, what I love about Dr. Best is, yeah, he comes out of a research, he comes out of the university system, and he's passionate about that, but he's also a person of practice. I see him the way he works. We see people, right? When I see Dr. Best, I see somebody who is doing the hard work around the research, and he's in prison systems and he's in provider systems, but he's also all about getting it into practice, which is always the hard part. So he spends a lot of time educating us. He goes around the world training. I mean, he just is really dedicated to How do you put this in the hands of the peer support providers that are going to be the navigators for people? How do you work with the ROSC systems to help them have an organizing way to think about this? So I'm not going to read off Dr. Best's bio. I mean, it's unbelievable. He's amazing. He's a PhD. He's written articles and chapters in 70 books. He publishes prolifically, and every time I talk to him, he's either talking the keynote at the National Association of Recovery Residents. He's going out to the California Consortium of Addiction Programs Professionals here in October. I mean, he is just out there educating us on what he's learning in his work. And I'm just awed by his work. We're actually partnering with Dr. Best on the next version of the Recovery Capital Assessment that'll help bring some outcome measures to the community. And then we're going to be working on a communities assessment. And so I've gone way too over my time here, but I just want you to know that the person that we're about to hear from is somebody that whenever I talk to him, obviously whenever I hear him speak, I always learn something. And with that, I'm going to hand it over to Dr. David Best.
Wonderful. Thank you so much, Tom, and thank you to both you and Carol for your very generous opening comments. And thank you to all of you for inviting me to speak to you today. It's a pleasure and a privilege to be here and to share what I hope will be some interesting, thoughtful ideas and to tell you a little bit about my work and where I'm going with some of my work. So I guess it's probably worth starting with a little bit of background. So I started many years ago, nearly 30 years ago. I did my training as a psychologist in the National Addiction Centre in England, which is based in South London. And we provided, at that time, treatment services for the whole of the South Thames area. In other words, all of London that's south of the River Thames, which is about 4.5 million people. So it's a big, big treatment population. But I got pretty quickly skeptical about the limitations of specialist treatment. I guess it would be similar generally to your IOP treatment. I spent a lot of time working in a opiate substitution program in South London, and sometimes spent working in an inpatient detox ward and for alcohol and one for heroin. But it struck me that we saw far too many people who either never left our treatment services or were in this horrible revolving door of in and out and in and out and never really seeming to move their life forward. And it struck me that no matter how good specialist treatment was, it would really only be effective if it was embedded within a recovery-oriented system of care. That treatment isn't always necessary, but very rarely is it sufficient. And I guess it's really dangerous as well if you work in especially acute treatment services to assume either nobody gets better or the people who do get better are kind of anomalous. And so when I first heard William White speak and when I started reading about recovery, it really was a revelatory to me. And it coincided with an invitation I had to speak at a 12-step graduation in a prison in the north of England called Lancaster Farms, where I was asked to go and preside at a graduation and give out certificates. And it was one of those great events where not only were there 10 or 20 people graduating, but there was also their families there. And that sheer sense of collective pride, achievement, really was a big transformative event for me in my thinking and the way I viewed how we should conceptualize and work on understanding recovery. And in the time since then, what I'm going to talk to you about is what has happened in my world since that time. And I'm not going to try and present these as my ideas. I've collected approximately 2,500 recovery stories in Scotland and England, in Australia, New Zealand, and Canada and America. And what I'm really going to tell you is my synthesis of what people in recovery have had to say. I don't think of this as a grand theoretical model, rather a kind of putting together of what other people have done. Now, I should also say, as a bit of a cautionary note, If you don't understand me, please put comments in the chat. You can have all the slides. It probably comes as a bit of a surprise to most of you to learn that English is my native language. It probably doesn't sound like it to you. But what I'm going to talk to you about is my own journey through the world of research and some of the things that I've learned and some of the things that I've studied and some of the things that I've found and some of the things that I've concluded. And one of the biggest challenges, I think, is how, as systems and policymakers, do we make sense of the transition from a traditional treatment model to a recovery model? Because it's complicated and it's difficult. And in your program, it says I'm going to talk about an interactionist model, and I'll do that at three time points during this talk. And that's kind of what makes the model of recovery and the development and effective evaluation of recovery-oriented systems complicated and difficult. But I shall move on. Next slide, please, Teresa. Wonderful. Thank you very much. So I'm going to start with some basic stuff. And I hope many of you will be familiar with some of these statistics. The statistics down the left-hand side, a framework down the right. So the statistics. According to the Substance Abuse and Mental Health Services Administration in the US, of all the people who have a lifetime substance use disorder, 58% will eventually achieve recovery. Now, at first glance, that sounds like a very good thing. Most people will eventually recover, but it does mean 42% of people with an addiction will die while still addicted. Not necessarily of their addiction, but with that addiction still with them. And I think one of the interesting questions is, can we up that percentage? How do we make that percentage higher? And incidentally, that's at the higher end of the estimates. Bill White's review of 415 papers estimated just over 50%. And there's big variations between studies. But I think it gives us both a kind of level that we should try and surpass. And the whole science of recovery capital is in essence a question of, well, two things. One, how do we know who's going to be in that 58%? And secondly, what can we do to support and help people be a part of that 58%? And the whole model of recovery capital is both a science in terms of prediction. This person is more likely than that person, but also the basis for an intervention. But it's not a traditional medical intervention or talking cure intervention. It's an interactionist systems intervention. And why I'm delighted to be talking at a ROSC event is because it seems to me that it's that systems level where we will have the biggest effect. And we also know it's partly to do with stages and where people are. That in the first year of their recovery journeys, the likelihood of relapse has generally previously been reported to be in the range of 50 to 70%. So if you have a detox or a rehab episode, chances are you've got around just over half chance you'll relapse in the next year. But if you make it to 5 years of continuous sobriety, that drops to about 14%, 1/4, as the second bullet point there suggests. And it will relatively plateau at that time. So if nothing else, what do we think of the powers of recovery systems and recovery models? It's to get as many people from that 70% risk to the 14% risk. How do we support people through that post-acute time when the answers are definitely not medications or specialist intensive therapies? They are about jobs, friends, houses, communities, those things that are about long-term integration endeavours. And the recovery evidence base is really about that, about how we support and sustain people to change. And one of the things I think that's crucial here is that we can glean stuff from the mental health recovery movement that's directly relevant. So moving to the right-hand side of this slide, there was a wonderful review paper in the British Journal of Psychiatry. Oh, back, please. Sorry. We're going. I don't know whether I'm going too slowly or if people are getting impatient who are doing the slides, but I'll say when we want to change the slides, if that's all right. So, yeah, the model. The model that came from the mental health recovery movement, based on a review of papers, was that people will be supported in the recovery when a service can do 5 things. And those 5 things are summarized in the acronym CHIME. And CHIME stands for connections, hope, identity, meaning, and empowerment. Now, sadly, in my testing of this model, it's not quite in the right order, but CHIMI doesn't sound as good as an acronym. But in effect, this is what happens. The fundamental starting point for any recovery journey is positive human connection with an individual or with a group. And that's where it all starts. And that positive human connection generates the hope that change is possible through what psychologists would refer to as 2 mechanisms. Social learning, which is basically copying. Something you have, I want, so I will copy you to get it. The second part is social control. If I am part of your group, there are certain things I am allowed to do and I am not allowed to do. And the group will help to mold and shape that recovery pathway. So connection generates hope that change is possible. And that hope is the motivator, the energizer, that then creates a virtuous circle of meaningful activities plus, which in turn generates the capacity for identity change. I am a person who can do stuff and achieve stuff. And that creates a sense of empowerment. Connection generates hope, generates a virtuous circle of meaningful activities, empowerment, and positive identity change. Wonderful. Now change slide, please. So the next study that I want to talk about, yes, perfect, was my own first big recovery study, where we looked at what predicted well-being in people in long-term recovery in Glasgow and Birmingham. And this was people in recovery from both alcohol and from opiates. And what we did was we tried to predict what the big bundles of predictors were that allowed people to make meaningful long-term change. And this study, I'm going to mention actually 3 studies here, but this study and the 2 that we come after it can all be classed as part of the Goya series of studies. And Goya is after the Spanish painter Francisco Goya. And I will explain what Goya means shortly. So in the first of the studies in Glasgow and Birmingham, what were the best predictors of people who had the better well-being and quality of life in recovery? Well, there were 2 bundles of factors. The more time you spent with other people in recovery, this is the connection part. Being around people in recovery is the potential triggering effect. The second bundle of factors surprised us more. And it was basically that the more you did of pro-social activities during a week, and we just counted up the hours people were involved in any kind of pro-social activity, childcare, community group involvement, volunteering, education, training, and employment. The more of that you did, the better your well-being was. Why is this important? Well, what it suggests is CHIME, positive connections to other people in recovery, and meaningful activities are 2 big bundles of things. But we were kind of criticized for this. We were criticized on the grounds of, how do you know it's not the other way around? So we repeated the study in 3 drug action team areas in England, and we published this in 2013. And we measured people who started or stopped either education, training, or employment. And what we found was really simple. We looked at their physical quality of life, their psychological quality of life, and their overall well-being. When people start meaningful activities, their quality of life and well-being goes up. When they stop meaningful activities, it goes down. People who were continuously involved in meaningful activities had higher scores in all 3 of those markers at each time point than people who didn't engage in any of those activities at either time point. In other words, it is not the case that engaging in meaningful activities is somehow a consequence of well-being. If you do things that are meaningful and provide you with a sense of purpose, your well-being goes up. Now, both of those studies were done in the UK. Both of them were done quite some time ago. But we repeated this in Florida in a study of 8 recovery residences who were all affiliates of the Florida Association of Recovery Residences. And we found exactly the same thing. People who stay in recovery residences for a long time have gradual reductions in their barriers and their unmet needs. But people who use that time to engage in meaningful activities, they have significant increases in both personal and social recovery capital. Okay, so why Goya? If you don't remember anything else from my talk now, please remember Goya. Goya is a highly scientific term that stands for get off your arse. The more you do, the better you will do. Positive connection plus meaningful activities equals Goya. Get off your arse, get out there and do stuff, because that creates the trigger to positive self-esteem, to increased sense of positive identity, and to a sense of human empowerment. Okay, next slide, please. And I'm going to talk to you a little bit, but only briefly. This is pretty up to date. The biggest study I've been involved in the last 3 years is something called the REC Path study, where we have looked at recovery pathways comparing men and women in Scotland, England, Belgium, and the Netherlands as a European funded initiative. And I'm going to draw your attention to a couple of things. We actually had found significantly, this was only drugs and not alcohol, incidentally. We found, and what we did was we took a group of people, no matter how long they've been in recovery, and we followed them over 2 years. So what did we find? Well, the first thing is that the biggest predictor of whether people relapse in our study is their previous relapse history, their previous recovery histories. In other words, in our first year of following this group of 300 people, 10% relapsed, way lower than would have been anticipated in the previous US published studies. There was a higher relapse rate among men than women, and I'll come back to some of the issues about gender differences later. But the massive difference is around recovery stage. The people we recruited at the start of the study who were in early recovery, who were in their first year, they were by far the most likely to relapse. Over 30% of them relapsed. In contrast, for people who already had 5 years or more in recovery at the start of our European study, 1.5%, or 1 in 60 or 70 relapsed. In other words, the more time you have in recovery, the stronger and more stable your recovery predictiveness is. Fits beautifully with the prior literature, but with one big exception. In all groups, the relapse rates were much lower than had previously been reported. I'm also going to tell you something interesting, because the study was called REC Path because it was about recovery pathways. And really our big interest, and what we're still looking at, is what services or supports do people use to sustain their recovery journey. And what we found was that people who engaged in both treatment services and peer-based recovery support services did significantly better than people who engaged in either on their own. Let me repeat that. Contrary to the views of many clinicians in the UK and Australia, where I've worked at length, it is not a case of either or. People who go both to specialist treatment and to recovery services do better than people who only go to one of those things. And crucially, people who go to recovery support services do significantly better in quality of life, social functioning, less justice involvement, and less unmet need. So both is better, but specifically, peer-based recovery support services are highly beneficial. And you will see this is an ongoing piece of work. You see the endless partners, and I should probably say thank you to my colleagues at the University of Ghent in Belgium, Ghent University College, and the IVO in the Netherlands. Okay, onwards please to the next slide. Now, I have told you a whole load of stuff you may or may not need to know about recovery, but I'm now going to focus down on recovery capital. And I'm going to focus on recovery capital because my reason for getting interested in this is the term recovery capital has been around for about 20 odd years. And the definition that is most commonly cited is from two of the key writers in this area, Robert Granfield and William Cloud, who describe recovery capital as the breadth and depth of internal and external resources that can be drawn upon to initiate and sustain recovery from alcohol and other drug problems. This concept draws partly from the idea of social capital. And social capital really dates back to about the 1920s. It's not a new term at all. Although it was extensively written about by the French sociologist Pierre Bourdieu and an American medical sociologist called Robert Putnam, again, of whom a little bit more later. What it's about is something that is about thinking about conceptualizing the component parts, the building blocks of recovery. But what frustrated me about it was that it had been talked about a lot, but never really operationalized and measured, in spite of the fact that William White, the guru and father of academic recovery research, and William Cloud had basically argued, look, long-term recovery is actually much better predicted on the strengths people have than on their pathologies or deficits. And the whole of the recovery model, and especially the recovery capital model, is about a big transition in thinking. It's a move away from thinking about deficits and problems to thinking about strengths. It's a move away from expert culture and professional clinicians to partnerships, empowerment. It's a move away from the clinic as the locus of change to the community as the locus of change. It's a fundamental philosophical paradigm shift in how we see things. Next slide, please. And what the recovery capital model allows us then to do is to take what has always been regarded as a kind of open, personal, individualized concept recovery and try and translate it into something we can count. Now, I have none of the academic skills or capabilities of William White, Robert Granfield, William Cloud, or any of these people. But what I have pushed hard to do is to start the question of counting. How do we start quantifying what recovery capital might be? So, starting with some work. So I took our data from Glasgow and Birmingham, and I worked with a very eminent New York recovery researcher called Alexandra Lodi. And we started thinking, how do we combine what our research shows us to say, what is recovery capital and how can we measure it? And our first thing, so we were commissioned by the Royal Society for the Arts in the UK to start kind of slicing it up and think about what are the things that make people recover. And I'll go through some of the components in a second, but this is the first interactionist component. Because again, it flips traditional addiction science logic on its head. So traditionally, you would start with a slice of the pie in the top left. You would start by saying, we want to build people up, to build up their self-esteem, their self-efficacy, their communication skills, their resilience skills, their coping skills. Those are key things. We want to build them up. And we'll do that, and we'll then utilize those skills to improve their social networks, to allow them to engage in what we originally called collective recovery capital, and we now call community recovery capital. A recovery capital model flips that model on its head. The idea is that in that 5-year journey to stable recovery, those personal qualities are what you are aspiring to. And it's the two other things, the social capital and the collective or community capital, that essentially provide the scaffolding around people to give them the time and the space to develop those internal skills and qualities. In other words, the model is predicated on the assumption that the social precedes the internal, but they are interactionist in as much as they are dynamic. The other thing is, It is not all about either a magic therapist sprinkling magic dust on you, nor is it about somebody showing loads of motivation and willpower and determination to change. It is about harnessing the resources of communities, the power of groups and social networks to provide people with both the desire, hope, and the opportunity, meaning to move themselves forward on that recovery journey. Next slide, please. And I'm really delighted to say that in your own US Office of National Drug Control Policy, this year, we have the overt recognition of the importance of recovery capital. And I have stolen a little excerpt from this year's presidential statement to show that recovery capital is now recognised and identified as a core part of this process and a core part of this change model. So this is critically important and a big part of what we are doing. So I'm going to say a couple more things about the mechanics and the technicalities of recovery capital before I move into what I think is the core kind of conceptual frame. Okay, next slide, please, Teresa. Perfect. Okay, so it would be unfair of me and inaccurate of me to claim credit for a lot of this stuff. So William White has written a number of monographs around recovery, including a fabulous 2009 monograph in peer-based recovery support services, where he talks about the kind of checklist of things that people would have to support their recovery. And so when we wanted to start counting and measuring, I was very fortunate to have the privilege of working both with William White and with a statistician and researcher from the European Monitoring Centre for Drugs and Drug Addiction called Teodora Groszkova, and also to work with a wonderful recovery service in Edinburgh called the Lothian and Edinburgh Abstinence Project, and where we were effectively allowed scope to test and develop these ideas. And really, that work led to two different things. In 2011, we published our first conceptualization, or our first operationalization of community capital, which was the Recovery Group Participation Scale. And then the following year, we produced what I think was a significant step forward. We produced the Assessment of Recovery Capital. The Assessment of Recovery Capital was a 50-item scale. It had originally been 100 items with 50 strengths and 50 deficits. But effectively, everyone said to us, well, we don't need more measures of deficits. We do that all the time. And we developed this and we tested it in various different services and specialist areas. And that scale had acceptable psychometrics. And thanks to some wonderful work done in the States by Stephen Arendt and his colleagues, I think the paper was led by Robert Sanchez, they showed that scores on recovery capital, the assessment of recovery capital, predict treatment retention and outcome. So it passes that big test of, does the scale have predictive validity? And I was delighted to work with a PhD student of John Kelly's from the Recovery Research Institute called Corey Bilsane, who produced a summary version of the assessment of recovery capital called, imaginatively enough, the Brief Assessment of Recovery Capital, or BARC for short. And so we've got this emerging history. But one of the things that concerned me, and one of the limitations of this model, was that there was a real concern that what we were doing was a kind of research or science activity. That what we weren't doing was something that was actually of use to people who wanted to work in the field and wanted to get that sense of, how do I use this stuff to help somebody who I'm coaching, where I'm navigating with them, where I'm working in a treatment service or recovery residence. Next slide, please. And so the model was fine, but it was insufficient. And the logic of the model then shifted. And the logic of the model shifted to something called MPE. And I need to acknowledge the work of John Lehman and Jessica Castile in the Recovery Outcomes Institute for the work they have done on developing the component parts of this. And in 2017, we published a paper which created something called the RECCAP, the Recovery Capital Measure, which was really about the idea that this isn't a science measure. This is a measure that's about actively doing things with people to generate recovery care plans. So it's not just that first step of documenting the science of change and measuring and modeling how change happens, but actually supporting and allowing the intervention in what makes a difference. And what makes a difference is primarily about engagement. So the model is called Measure, Plan, Engage. The model underlying this is that you create a score, you measure somebody's recovery capital, you utilize that to work with them to plan the next stage, and then that is the foundation for active community engagement. Go back to the original pie where community capital and social capital are the vehicles or the scaffolding that afford the growth of personal capital. Can we move on to the next slide, please? And Tom has been working with me on a new variant on this model. And, you know, it's important to say this is emerging ongoing science and emerging ongoing research. And it's important to say that, just to reiterate this point, the ultimate aim of any recovery capital model is to build those internalized resources. And I now increasingly would define a recovery capital as the resources and capacities that allow people to achieve a meaningful and fulfilling life. So what is required for that? Well, some of them are those internalized resources and skills that people have: self-esteem, self-efficacy, coping, resilience, communication. They are the essential components, but they are built via social recovery capital. Engagement with positive individuals, engagement in opportunities and access in the community. And that splits in itself into those specific to recovery: charismatic recovery champions and coaches, engaging positive recovery groups, whether they're 12-step or any other kind of recovery group, but also community resources like jobs, like houses, like access to education. In other words, the growth of the personal recovery capital is predicated on the access to recovery groups. And in a study I published in 2008 that really started a lot of this work for me, I noticed that when we talked about the triggers for recovery, it was quite often people would talk about it was about like a bad thing had happened on top of them being sick of the lifestyle. So the trigger for starting was event-based. However, what sustained people in the recovery journey was social networks, moving from using networks to recovery networks. And in the reanalysis of Project Match by Longabout and colleagues, they found exactly the same thing. The biggest predictor of alcohol recovery was switching from network supportive of drinking to network supportive of recovery. In essence, this model is chime in action. What I am arguing here is that recovery is predicated on positive connections generating hope. That combination also generating the tendrils and pathways of navigation into community resources to allow the development and growth of those internalized characteristics. Next slide, please. And I'm sorry with my food obsession. It's probably just as well you can't tell from where you are how much I eat, but having gone from pies, we're now moving on to the dessert. We're now on to ice cream. So the ice cream cone of recovery. You will see on the right-hand side, there is an ice cream cone. And don't look at very appealing ice cream cone right enough because it's blue and grey. But at the bottom of the ice cream cone, you'll see the little person. And the bottom of that is their personal recovery capital. And the idea there basically is it's a hot day, so it's not based in Scotland, and that the community levels and the social levels drip down, that they feed into this person. But the idea of this is also, and the second core interactionist point, and where it's crucial for ROSC, is that as that happens over time, those community connections and those social networks generate resources and strengths in the community. In other words, the first person who recovers in Maryland should not have the same journey as the 1,000th person, because for the person where there is an established recovery-oriented system of care, there should be a much more sophisticated lattice and set of networks and resources into mutual aid groups, recovery community organisations, but also into employment, housing, and all those other community resources that are essential, not just to start the journey, but to sustain the journey. And this is the key interactionist point. And I'm going to talk a little bit about some overlap with crime reduction theory. But before I do, I'm going to mention my own academic mentor and guru is a man called John Braithwaite, who works at the Australian National University in Canberra. And he will frequently start talks about social capital by saying to students, as we all know, financial capital, if we spend it, we have less of it. A sad reality all of us are very aware of. It is very different with social capital. With social capital, as you use your social capital, there is more of it afterwards. And they are the sprinkles. As people in recovery engage in community growth and community development activities, the community itself benefits. There is growth in collective well-being. Next slide, please. Now, how does this relate to John's work? And John is a very eminent criminologist. My ice cream cones link to his concepts of ink spots. In my language, I talk about the social contagion of recovery. He talks about the cascade of crime reduction. Many of you might be aware that in all but a few countries around the world, since about 1992, crime has been dropping. Overall crime rates have been dropping remarkably consistently. The UK, Australia, New Zealand, Europe, America, Canada, very similar globe overall pattern. When we look at why this has happened, it's confusing. And one of the few actual intervention techniques that appears to be effective is hotspot policing. High profile, highly active, intensive policing. But what's interesting about hotspot policing is where it happens, crime doesn't just move. It doesn't relocate to the next street or the next borough. Where you get effective hotspot policing, you get reductions not only in the target areas, but the surrounding areas. And what you also see is an increase in what criminologists have referred to as collective efficacy, which is the level of connections in neighbourhoods and the level of trust in neighbourhoods. And in essence, what John Braithwaite has argued is that crime reductions come from those areas of intensive activity that lead to increases in collective community trust, the growth of a radius of trust and openness and connection in communities leads to what he's referred to as a cascade effect or an ink spot. In my world, that translates to the notion of contagion. For him, it's ink spots. And what you have is this wonderful piece of abstract art in front of you that shows you that me and my colleagues aren't very good at doing drawing. But what it attempts to show is that the growth of the recovery community is about the effective championing, nurturing of existing successes based around community resources and not the McDonaldizing of success, because we've tried that and it doesn't work. An ROSC, a recovery-oriented system of care, will work effectively where there is this ink spot contagion, where there is this ice cream growth of sprinkles on the top. Anyway, enough theory. But that's the interactionist model, that individual successes are predicated on social networks and community engagement, but leave a residual benefit of the sprinkles and so change the communities. It's not just the individual in recovery or their sponsor or their coach who benefits. It's the community. And that is the indicative part of what makes a successful recovery-oriented system of care. Next slide, please. And how we measure this? Well, how do we measure this? We measure this by doing two things. At the individual level, the basic notion is we look for reductions in barriers, acute barriers, and reductions in unmet needs. But the fundamental premise of a recovery capital model is growth-based. That growth in those key areas of personal, social, and community capital build commitment, build quality of life and life satisfaction. And we can count these things. It is nonetheless true. Recovery is a personal, individualized process, but it's embedded in and predicated on a process of social and societal engagement and interaction. And that's the interactionist effect. What does this do for you on a kind of individual client level? Next slide, please. What it allows is the engagement of a score profile to build a personalized recovery care planning model. And this is absolutely essential. But in essence, what we have here is a mechanism not just to do the first bit, not just for people like me to be able to count and measure and say person X has a better chance of recovery than person Y. What it allows us to do is to say, this is what you might start doing with person X as a coach or a navigator or a service, or indeed as a system to support their recovery journey. And the work that Tom and I are involved in around recovery capital assessment is in essence an attempt to do exactly that kind of thing, to build those personalized plans on common, quantifiable, measurable data. Next slide, please. And it's also really important to say that we can identify who to prioritize for that community engagement. It's not just a question of everybody gets assertively linked to community groups. We know that the point of community engagement is about identifying those assets that match up to individual needs. Crucially, it's not just a directory, it's about creating pathways to those pro-social groups. And really the last 5 minutes or so of my talk will focus on exactly these questions. The aim is to reconcile the numeric quantifiable scores individuals have with those individualized, personalized objectives. I want to be the director of the Maryland ROSC. Well, what do you have to do to get there? Well, firstly, you need to do a bit of reading up about what an ROSC is, and then we'll go from there. It's about matching up their strengths, and it's strengths-based. In a recovery model, we work on the assumption that you use strengths to build strengths. Those strengths aren't all internal. Those strengths are partly about access to resources as well as internal resources. And the aim is to build connection, to build hope, and to build contagion of positive change. Okay, I hope I've got across this notion that the notion of building recovery capital is partly about building internal qualities, but the mechanism is at least in part social and societal. Next slide, please. So who needs this form of community engagement? Because not everybody will. You make these decisions based on the levels of capital people have at the starting point of this process. But there are two primary groups of people who need effective linkage in and assertive linkage into pro-social community groups and activities. Those who have no social networks and those who have social networks, but those social networks are heavily mired in drug use or offending. Excuse me. So, the steps. What are the assets out there in your community? How do you build those human bridges? How do you build that lattice of community connection? And not everybody is at an equal point for engagement. So you have to make sure that people are prepared and you create models that are both in reach. And I'll come on to this with two of my PhD students work in a second, and outreach, where you take people to think. But ideally, people come to you as well. And that you create these feedback loops and reciprocal development. I'm just going to mention one more study. So I want to be clear that community engagement is an assertive process. The Goya, get off your arse, applies just as much to recovery navigators, to recovery coaches, as it does to professional workers and people in recovery. So I had a colleague called Victoria Manning. Well, she's still called Victoria Manning. And we did a study at the Maudsley in 2012. which is Manning et al., and I can provide the reference for anyone who's interested. And what we wanted to do was to get people who were entering an emergency admissions ward to attend at least one Alcoholics Anonymous, Narcotics Anonymous, or Cocaine Anonymous meeting during their 10 days of emergency admission. We randomly assigned them to one of three conditions. In the first condition, they were assigned to leaflet only. In other words, they were given a leaflet telling them about the meetings. In condition 2, the booking-in doctor actively encouraged them to go and attend a mutual aid meeting. In condition 3, a peer talked to them about the meeting, took them to the meeting, and took them for a coffee afterwards and asked them how they got on and explained what had happened. What were the findings? In the peer assertive condition, there was more meeting attendance in the week they were on the ward, the 10 days they were on the ward. In our follow-up research session, there was more meeting attendance in the 3 months after they left the ward, and there was less substance use in the 3 months after they left the ward. There are 3 conclusions from this study. Number 1, giving people leaflets is the pointless abuse of dead trees. Conclusion number 2, and apologies to any medical people in the room, a booking-in doctor is only marginally more useful than a dead tree. Conclusion 3, peer-based engagement is an essential component of effectively bridging those links to community resources and community assets. Next slide, please. And you can be creative about this. So I have 2 PhD students, one of whom I'm delighted to say, Beth Collinson, passed her Viva last week, so will soon no longer be a PhD student. And she is based in Sheffield in the UK. The other student, Zeddy Chowdhury, is based in Auckland in New Zealand. And what they have been doing is they have been testing this model around how do you get people to engage. So what we've been doing is we've been trying to create a model where people who are the who are taken to meetings or taken to engage in any community asset, whether it's 12-step, whether it's football teams or singing clubs or choirs or yoga classes, that they then rate those things on availability, accessibility, and connectedness. And that if it works for them, they then take other people. They become the human bridges into those groups. And that whole science is an emerging science of how we effectively engage people in that process. So where do I want to go with this? Well, this is an incredibly early but exciting time. It's really important for me to say that the science of recovery capital is emerging at the moment. And with a colleague from the Recovery Research Institute called Emily Hennessy, we're currently writing a paper on what some of the gaps are and what we think we don't know. So it's important to say it's early. But recovery capital offers something that we haven't had in the recovery science world before. It offers us a space for quantifiable, testable measure that allows us both to develop our thinking and our concepts, but also to offer something very practical that is not only predictive. In other words, if you have this level of recovery capital, we would say you have lower or higher chances of sustaining recovery. But crucially, something that will also afford you the opportunity to support people more effectively, based on the idea that recovery capital is about 3 things: about the individual and what resources they have, about the social groups they belong to, and about the community resources they can access. And the corollary or flip of that is about the stigmas, the barriers, the obstacles, which we would call negative recovery capital in all 3 of those areas that would stop people achieving these things. So next and final slide, and I'm not really going to talk about this stuff. There's a whole pile of other stuff going on. There's some really exciting work going on in various places around this. And I'd just like to thank you all for your time and see if there are any questions anyone has of me now. So thank you very much.
Hey, Dr. Best. Oh, gosh, thank you. You explain everything so well. But I'm wondering, I'm looking in the chat box. I don't see any questions. Actually, I do see one. Have there been any studies that focus specifically on opioid use disorder? And if so, are there similar findings?
I mean, I would say, in fact, that the vast majority of studies have been done on opiate users or alcohol users. Probably where there is a bigger gap is around stimulant users. I don't think the literature is as strong. And virtually all of the recovery studies I've done, so the European recovery study I talked about, the vast majority of people were people with a history of opiate dependence. A small proportion of them who were still in medication-assisted recovery, but the majority of them in abstinent recovery. So yeah, most of our understanding, most of our knowledge about recovery and recovery capital comes from a combination of heroin and alcohol. John Kelly has started doing some work in Mass General, which tries to expand this out and looks at differences in recovery patterns, including things like cannabis and stimulants. But yes, absolutely, much of the work has been done on opiates.
Great, thank you. And that question came from, I believe that was Linda Bryan from our Baltimore County Health Department. So I'm seeing wonderful, Dr. Best, great presentation. So I'm going to jump in. If anybody has questions, please put those in the chat box. But Dr. Best, when are you back in the States again? What's your upcoming schedule look like? And if some of the folks on the call want to get in contact with you, how would they go about doing that?
Yeah, well, when I'm in America next is entirely dependent on your government. So I was due to be there 2 months ago. I've been involved in this wonderful project about training the staff in 2 therapeutic courts in Boston and Rhode Island, where I have 4 days of working with a wonderful group of colleagues in drug courts in those places, but I wasn't allowed in. So I didn't get there then. At the moment, I am planning to come to the NAR conference in Richmond in Virginia, which I believe, I'm going to get the dates wrong probably, it's the 24th and 25th of October. And then I'm at the CCAP conference in Newport Beach in California, which I think is the 28th and 29th of October. I'm looking nervously at Tom to see if I've got the dates right. But it all depends on whether I get what is called a national interest exemption to allow me to enter the country. Otherwise, I'll be turned around at the airport and sent back where I came from.
Oh,
and in terms of getting in touch with me, I'm more than, if I can work out how to use the chat, I'll put my email address in it.
And actually, so that was my question. I wanted to be able to share your contact information so we can take care of that for you.
That's absolutely fine. That's absolutely fine.
I mean, it's just, and look, I like your reference to food because I happen to be a foodie, but I know people are asking here about slides. Everyone, Dr. Best and all the speakers for today, we will upload those slides onto the beforeitstoolate.gov website, so, and the recording. So you will be able to have access to these slides and listen to it again because, you know, it's worthy of listening to many times over. But anyone else, any other, again, I'm seeing excellent, great presentation. Anyone else want to chime in? Any of our drug court professionals? I know that there are some drug court folks on the phone or on the call. Okay, it doesn't look like it. Okay. All right, with that said, we are a little ahead of schedule, Dr. Best. So I know you have to jump off the call because you know, first of all, can I just say this? You lived up to your name, Dr. Best, because you are the best, okay? And we know you're all over the place, and by that I mean you're all over the world. And
no, I'm frequently all over the place as well.
I'm serious, and we can't thank you enough. I speak on behalf of all of us here. We seriously can't thank you enough for taking time out of your busy schedule because you really are extremely busy. So thank you so much for that.
My pleasure. Thank you, Carol. And good luck.
We will
with
definitely
the rest of the event.
you. Yeah, we'll definitely see you in the States, I hope soon. And please keep us posted. I know you'll keep me posted, and then I'll get that information out to everyone on this call. So thank you again for that.
Thank you very much.
Have a
Bye.
great day. Okay. Hey, folks, we are a little ahead of schedule, but about 10 minutes. So what we're going to do is give you a little break, okay? So it's time to go ahead. It's not really time to go ahead and look in the chat box, but if you like, go in the chat and check your chat, right? Make sure that if you are a person who leads a ROSC in your community, county, city, to put that in the box so we have that. We're going to take about a 9-minute break now, and we'll be back with Peter D'Souza of Hope House. And he is actually, our Hope House is the sponsor for our next speaker, Dr. Hanar Hernandez. So take a break. Come back if you have any questions for me. You all have my number, or you can put them in the chat, and I'll get to those as soon as I can. Okay? All right. Thank you, everyone. We'll see you back at 11:44. folks, heads up on the time. We have 1 minute. So hopefully you're grabbing something to drink and maybe just collecting your thoughts, and we'll see you in 1 more minute. Okay, folks, we're back. So I just have to tell you, I'm just thinking about what Dr. Best said about the Goya. You know, I was surprised by that, so I'll be honest with you. So anyway, right now we're actually should have been taking a lunch by this point if we were going to be in person. But since we're not, our sponsor for that lunch was Hope House. And Peter D'Souza, the executive director, is here with us to share a few words because he actually graciously offered to sponsor our next speaker, Dr. Hernandez. So, but before we bring Dr. Hernandez out, Peter, are you there? Peter?
Yes.
Okay, can you unmute your video? I don't know if you can, or Teresa, if we've got that. Is he seen?
I don't know what.
Okay, just hang tight. There you go. We got you.
Okay.
All right, Peter, thank you so much. Thank you for joining us today.
You're welcome.
Did you want to share a little bit, since you're sponsoring our next speaker, would you like to share a little bit about Hope House? So folks, because I know there's some mix up here, you know, people think it's a place in Baltimore City, and so maybe you would want to share a little bit about Hope House.
Sure. You know, Hope House Treatment Centers is one of the largest inpatient medical model treatment centers that provides excellent services to patients in the community. We treat patients from the whole of Maryland and beyond. Our referrals come from crisis stabilization centers, hospitals, outpatient programs, and mostly by word of mouth. We keep our focus entirely on the patient, meeting him or her where they are at, and providing them with unconditional kindness. The biggest challenge we face right now is the devastating effect of the pandemic on our patients. It has crippled our services with people testing positive for COVID. Our future projects are to acquire the property that we are leasing from the state, build a much needed regional crisis stabilization center with a seamless transition into treatment, and rehab many of the buildings that are decrepit for long-term care of our patients. I am also very glad to announce that Lisa DeHorty, the former CEO of Recovery Centers of America and Serenity Acres, has joined us as our Chief Operating Officer, and D. Carol Boyer, who has just planned this whole virtual ROSC meeting, will join us within days as the Chief Community and Government Engagement Officer. The pandemic has overshadowed the opioid crisis in Maryland, and all of us are now focusing on mitigating the opioid crisis. the state, the county, and treatment providers are working hard to save the lives of those caught up with the opioid crisis. But treatment is just a part of the whole recovery process, as Bill White has explained in his excellent remarks. Most of our efforts are front-end loaded, that is, crisis reduction and stabilization. There are hardly any resources applied to sustaining a seamless long-term recovery process. Hence, the cycle of crisis keeps being prolonged and demanding our entire effort. None of the insurance companies reimburse us for long-term care treatment, even though it is acknowledged to be a chronic illness. I have personally attended a lot of ROSC meetings in the past. Dr. Aliya Jones, in her presentation, mentioned that one of the main goals of ROSC is to enhance community partnerships. Many county ROSCs are struggling because the state and counties are busy collecting information to justify continued funding. It is okay if it is not the main and the only focus of the meetings. They do ask for provider concerns, but then they get lost in the shuffle. Our focus should be to improve ROSC, and in my perspective, the treatment providers, the state, and the counties, under the auspices of the ROSC program, should design a seamless long-term care program funded by the state to help break the cycle of repeated crises that our patients are undergoing. Let us stop repeating the same mistakes again and again and work to make the ROSC system relevant. Thank you.
Thank you so much, Peter. Thank you, thank you, thank you. Teresa, do you want to take over? Hi, Dr. Hernandez.
Yes, absolutely. And congratulations, Carol. Thank you, Peter. Next, we'll hear from Dr. Hanar Hernandez. Dr. Hernandez is Puerto Rican, bilingual, and has worked for over 33 years in the health and human service field, developing, implementing, and evaluating culturally and linguistically intelligent youth and adult health prevention, intervention, treatment, and recovery support programs. He is a person in long-term recovery from addiction and is committed to eliminating health disparities by participating in processes that build equity. He's a master trainer and facilitator and provides individualized technical assistance and support to organizations that provide substance use disorder, mental health, and gambling prevention, intervention, treatment, and recovery supports. Also, Dr. Hernandez has over 30 years of experience in delivering mental health services, addiction counseling, and clinical supervision to professionals in the field. We're very fortunate to have him here today, and again, we thank Hope House for making that possible. And without further ado, I'll hand it over to you, Dr. Hernandez.
Dr. Hernandez, are you with us? Oh, there you are. Dr. Hernandez? Okay, folks, so
Dr. Hernandez, we
My
can.
apologies.
we
Oh,
can-
there you go. Were
Okay.
you on mute?
Yeah, my apologies. I mute myself at least 15 times a week.
Hey, thank you so much. It's so great to see you again.
Good to see you.
Okay.
Thank you.
All
Thank
right,
you,
take it
Carol.
away.
Thank you, Carol, for the invite, and thank you for that wonderful introduction. It looks like we are ahead of schedule, so I'm happy to be here. with you. My name is Hernandez, and happy Recovery Month to everyone here. We know that recovery is for everyone, every person, every family, and every community. I'm going to send off my slides if anyone is interested, and you see my email as well as my phone number, and you can look me up through Facebook and or Instagram and stay connected. And so I've worked for 33 years, going on 34 years in December, in the field of health and human services with a specific focus on substance use disorders and mental health. My primary focus continues to be on understanding disparities and addressing equity in our field. And I've worked in inpatient, outpatient, all of that stuff. You see that I am a person who has done this work for many years, and I continue to learn from folks. At the federal level, I do work on a number of SAMHSA funded initiatives across the country, and I've worked in every single state except the state of Alaska. So I'm really happy to be here. Once again, thank you for the invitation. Just to give you a little bit more about myself, I'm a certified prevention specialist, and I am licensed as a drug and alcohol counselor at the advanced level and certified as well. I'm the president of the Certification Board of Directors here in Massachusetts. And yes, I have a PhD, and I have a picture to prove that in terms of my graduation, but I also have a GED. And my GED, I earned it in prison. And it was more difficult to get the GED in prison than to get a PhD out here. I want to let you know that I am a person in long-term recovery, as was said earlier. But what that means for me is that I haven't used a substance, including alcohol. In December, it will be 35 years. And if you're doing any math this early in the morning, someone gave me an opportunity when I did not know what I was doing, and I didn't know why they were hiring me. But they gave me an opportunity, and here I am close to 35 years later, learning and making a contribution in our field. What that enables me to do is to be a productive member of my family, my community, and to do this type of work. I'm going to ground my comments today and my presentation in a couple of areas. Number one, in what research and data say about issues of disparities and building equity, substance use and mental health disorders. Also on lived experience, because I think that we have a responsibility to highlight lived experience, because those of us with that experience have a lot to learn and teach others about what it means to enter and sustain recovery over time. As you heard, 34 going on 35 years. This is the only point in time in history where I can say that I'm a billionaire, because 32 years in recovery equals 1 billion seconds, right? Imagine that. And then I want to let you know that my recovery is not just because of what I've done. It is grounded in the collective. There are thousands of people that you don't see behind me who have supported and continue to support my recovery on a daily basis. So I'm forever grateful for them. So, you know, we have 23 million people living in the solution, which is recovery, or recuperación in Spanish, right? And so, you know, it's important to understand that, because we need to be strength-based, and we need to highlight that recovery is possible, that there are millions of people, which translates into millions of families, which translates into countless communities across the US who are experiencing what it means to live in the solution, to live in recovery. And we have a lot to learn from the recovery community and a lot to be grateful for. I know that I am. As a member of that community, I continue to learn on a daily basis. Having said that, we need to pay attention to issues of history and context, because they matter. You know, the things that have happened in our field have happened for very specific reasons. And if we don't understand what has happened, we will be repeating the mistakes of the past. And so maybe you've been to the conferences and meetings where the mantra is addiction and mental health don't discriminate. And when people say that as presenters, there's a whole bunch of people who clap and say, yes, that's true. And I understand what that means for people. But the reality is that I don't clap, because there is something else that should be said when we say that addiction and mental health don't discriminate. and that is that individuals discriminate. And if you have been on the receiving end of discrimination for whatever reason, sex, gender, sexual orientation, race, ethnicity, language, documentation status, what have you, you know what that feels like. And the other spaces and places that discriminate are systems. And our field is comprised of a series of systems. And those systems have policies, procedures that many times are discriminatory. As a matter of fact, yesterday I heard from one of the participants in one of my programs that said, listen, in a training program that I run, and she said, listen, I work at this place, and there I was, and it's a treatment facility for males, and there was this Latino guy who didn't speak Spanish, and they instructed me as the person who does speak Spanish to tell him that he needs to leave by tomorrow. Those are discriminatory processes. In the face of that, she said to me, listen, Hanar, I was interested and willing to be a translator for him, but they didn't allow me to do that. Those are examples of discriminatory practices. And so the other thing that I would be remiss if I don't mention, and some people get upset when I say this, but it is a fact. It is a fact not created by me, but created by the system. That the system that we have by and large was created for white heterosexual males. Now, this statement doesn't mean that I am against treatment for white heterosexual males. I'm pointing out the reality of the field. And so imagine for a moment if we had a treatment system that had 2,000 residential beds, right? 2,000 residential beds. Can white heterosexual males get in to that system? The answer to that is yes. Now, are there enough beds for white heterosexual males? The answer to that is no. And those are two different things, and we can hold two different things in our head and think about them in critical ways, right? Now, if you are a female, can you get into those 2,000 beds? You can, but it gets more difficult. If you are a female that has kids, can you get in? It even becomes more difficult. If you are a female with kids who is monolingual and doesn't speak English, it becomes next to impossible. Next to impossible. So our system was not created for everybody. And I'm using the example of females, but we can use the example of people of color, of gay, lesbian, bisexual, transgender, questioning people. We can use the example of many communities that have been excluded from participating in recovery processes and treatment processes. And we are the folks who say we understand substance use disorders. Isn't that ironic, right? And so that part of the reality we need to think of as we move forward and build ROSCs that are inclusive of all people and not just some people, right? There are deliberate silos, and I'm sure that you've spoken about silos this morning, right? Because we're talking about ROSCs and the need to develop a ROSC or ROSCs across the country and in your home state, territory, what have you, that are reflective and conducive for every single person who needs access to treatment and quality of care, as well as access and quality of care regarding prevention, intervention, treatment, and recovery support services, right? So what do those silos look like? Mental health, many times located in one part of town where, people have to go to that spot, right? Health services, yet in another part of town, people have to go there, and we're doing referrals back and forth. Human services, yet in somewhere else, right? And people, again, need to go and access those, and we're doing referrals back and forth. Substance use disorder or addiction treatment services or recovery supports are located somewhere else. Now, why is this? Funding has a lot to do with how and why we created these silos, but we have been responsible for maintaining them. And if we're talking about ROSCs, we have an ethical and moral obligation to bring silos down, right? Many times these services are in the same building and they don't even talk to each other. The people from treatment don't understand prevention and vice versa. People in recovery supports have difficulty understanding folk who work somewhere else. And for the life of me, I have never understood why. I understand the rationale of why those systems were set up, but I don't understand why we feed into a system that is designed not to treat our people well. In addition to that, in the substance use disorder world, we've had punitive approaches, right? We've never had the funding that we need or require to be able to do our work well. The majority of the funding goes to treatment. I am not against treatment, but a reality is that not everybody needs treatment. And as a matter of fact, we need to fund the entire continuum: prevention, intervention, treatment, and recovery supports, which include the multiple pathways of recovery. And so it's punitive because we don't fund every single point along the continuum. It's a flawed design as far as I'm concerned, because this is what has happened traditionally. If people have symptoms, signs and symptoms of their disease, we have kicked them out of care. For some people, it is because they have relapse and we've kicked them out of care. Imagine that. Imagine people who have diabetes going to the doctor with blood sugar levels out of control and the doctor saying, you can't be here and you can't come because you didn't follow directions. That would never happen. That would never happen. Why does it continue to happen in our field? Why does it continue to happen? Not just because of relapses, but because people exhibit signs and symptoms of their disease. You know, we call them liars and manipulators and frequent flyers and all that nasty language that doesn't help anybody. And for the life of me, I still don't understand why those of us who took money and said that we understand substance use disorders continue along this path of treating people badly. The other thing that we have done sadly in this country is that we have incarcerated people for having mental health and substance use disorders. We have criminalized substance use and mental health, right? And I'll talk a little bit more in depth about that a little bit later, but let me give you this. We have also criminalized color because people of color are disproportionately impacted by mass incarceration in this country. I'll come back to that in a moment. And so one of the questions that I ask you is, do you think that we have an opioid crisis, right? And when I ask this in conferences and meetings, for the most part, you know, people say, yes, we have an opioid crisis and, you know, that sort of thing. And here's what I say to that. Approximately 97,000 people died in 2020, the largest number of people who died in a 12-month period in U.S. history, right? The largest number in a 12-month period. But you know what? I don't believe that we have an opioid crisis, and here is why. We have a crisis in the criminal justice system. We have a crisis in health. We have a crisis in substance use disorders that is not just opioids. Our folks are dying from cocaine. More African Americans die of cocaine than from opioid overdose deaths. Our folks are dying from alcohol-related deaths. That you know, when you take all of the other drugs combined, more people die of alcohol, right? Of alcohol-related deaths than anything else. We have people, right, who are dying from methamphetamine. You know, it's more complicated than just opioids. Opioids are in the mix, right? We have a crisis in unemployment opportunities for our folks, in education for our folks, in affordable housing. How many of you are trying to get people housing, right? You know this. And we're trying to develop ROSCs that are reflective of the needs of our populations, right? We have a crisis in mental health. Here's what happens. When we have a myopic view of what the problem is, we come up with myopic solutions that sustain the status quo over time. If you haven't noticed, my slides are non-traditional. I can do the traditional slides and read at you, but that's not my style. And so what we need to do is to have, I think, a more comprehensive understanding of what the problem is so that we can come up with comprehensive solutions, plural, not one thing, because one thing is not going to resolve the issues that we're confronting. And so one of the things that near and dear to me that I think everybody should understand is this whole concept of disparities, right? And these are, disparities are defined by Healthy People 2020. I encourage you to go to that website as a racial, ethnic, or behavioral health outcome that is seen to a greater or lesser extent between populations, right? They are particularly linked with social, economic, and or environmental disadvantage. So think about the people that you work with, think about what they struggle with, what they look like, race, ethnicity, right? And other characteristics that are historically linked to discrimination. And you will begin to think about how disparities emerge and how they're sustained, right? I'm going to pick on one, and that is mass incarceration, because we have disparities in mass incarceration. In 1970, there were 200,000 people incarcerated in the US. Fast forward to today, that number skyrockets to 2.3 million people. If we add the 5 to 6 million people who are on probation, house arrest, or parole, we will see that we have almost 10 million people involved in that system. That system that we call the criminal justice system, I call it the criminal injustice system for the reasons that I'm about to say next, right? So think about this. This is 10 million people, 10 million families, countless communities across the US who are experiencing mass incarceration. And most of the people who are incarcerated have a substance use disorder, upwards of 98% in the county where I live. Studies at the national level are around 80 to 85%, and about 60 to 65% have a mental health issue going on with them. Now think about that in terms of criminalizing mental health, criminalizing substance use disorders, and what that means. The US has the largest prison population per capita in the world. If you want to scream USA #1, this is the opportunity to do that, right? Now, there have been deliberate policies that land us at this point. This isn't because some people are more prone to violence and crime than others. It is because of deliberate policies, including deinstitutionalization in the 60s, the war on drugs in the 70s, and beyond that, we still are dealing with the policies of that, criminalization of behaviors that at one point in time in history were not criminal, powder versus crack cocaine and sentencing, right, where primarily African-American, Black people, Latino folk got huge sentences for possessing small amounts of crack cocaine when affluent people with large amounts of powder cocaine didn't get the same sentences. Mandatory minimums, 5, 10, 15, 20 years behind a wall with very little support for reentry services, those sorts of things. Voting rights stripped in upwards of 20 states if you have a criminal offender record. Thankfully, I live in Massachusetts and I can vote here, but if I move to a state that doesn't allow me to do that for stuff that I paid for and did over 34 years ago, really? That's the treatment, disenfranchisement of our folk? School zones designed for inner cities. The people who live in inner cities, by and large, are people of color. In the city where I live, only 1,000 feet is not a school zone. School zones are schools, parks, daycare centers, and they operate 24 hours a day, even when those spaces and places are closed. You get 2 additional years tacked onto your sentence of mandatory time for a school zone. 3 strikes and you're out. How many of you know people who are doing 3 strikes, life in prison? I have a personal friend right now. He worked in our field for 7 years as a recovery coach, providing services, had a reoccurrence, or what some people know as a relapse, and he stole a car. He's doing life in prison for that. There's thousands of people across the US doing life in prison. There's a few people who are doing life in prison in California for stealing food, 2 slices of pizza. That was their 3rd felony. Massive prison construction, right? Because in order to house people, we needed to do massive prison construction. The majority of people who work in those prisons and jails have very good salaries, very good benefits, and most of them are white and are from affluent communities. That is just a fact. You don't want to believe me? Look at the literature. Then there's the privatization of prisons and jails. Commissary, food, phone calls, you name it, within prison systems and jails across the country. Those things have been privatized. In Massachusetts, families spent $20 million last year to receive calls from people who are behind the wall. These are poor families, by the way, poor families, right? And so who's profiting from that? Yes, prisons and jails are traded on the New York Stock Exchange. So if you have a retirement account, you might have money in private prisons and jails. So there's a profit factor here, right? And then to round things off really nicely, criminal offender records, which prohibit people from getting housing, a job, their kids back if they're in the system. It's discriminatory all the way around because those are things that I did a very long time ago. Why are they still on my record and our records, right? And so think about those deliberate policies. And the reason why I mention deliberate policies is because when I ask people, do you think that the criminal justice system is broken? The reality is that many people say yes, and I disagree with you respectfully. That system works exactly the way it was designed to work. Exactly the way it was designed to work. Because these policies were put into place to affect people in a very specific way, and they have. Now, to those effects on individuals, think about this. This is a Pew study from 2018, and these are plea bargains, right? 97% of all cases are pled out at the federal level, 94% at the state level. This is what we call due process in this country. If those are the numbers, the reality is that this is by and large poor people. And we don't have our day in court in front of a jury of our peers. It looks like this. If we're sitting in the pen right now, waiting to be sentenced, our public defender, because we're poor by and large, we're going to get a public defender that has 150 to 200 people on their caseload. Is going to come to the back in the bullpen and said, Hanar, they want 20 years. The DA does. Do you want to take 10? So-and-so, Carol, they're asking for 15. Are you willing to take 5? Peter, they're asking for 5. Are you willing to take 1? Teresa, they're asking for 1. Are you willing to take probation? Those are no-brainers for people in bullpens across the country. We'll say yes to that because we don't want to do the high number, right? And so, this system works exactly the way it was designed to work. Here are the outcomes. The majority of people in prisons are men, but females are in prisons too, across the country. Look at the over 100,000 who are in local jails. The majority of them, 61,000, are not convicted of anything, but they are poor and they can't afford bail. So they sit there with everybody else, right? Of the convicted ones, it's 40,000. But if you take a look at what they're convicted for, is primarily drug-related charges. At the federal level, we'll see the same thing. Let me give you a slide that speaks to issues of males in this country. And, unfortunately, this doesn't talk about Native Americans who also experience this at a greater clip. These are young males, right, between the ages of 25 and 29 per 100,000. So think about 100,000 people. For whites, in terms of being in prison, it's 1,437. For Latinos, Hispanics, or Latinx folks, it's 3,892. And then look at what it does for African Americans or Blacks, 8,932. By the way, let me just point out that number that you see there lower for whites, those are poor whites. Those are poor whites. That's not affluent whites, right? And so we can see the impact of the system across the board. Blacks, Latinos, and Native American are not more prone to violence or to any other criminal activity than anyone else. So why are we incarcerated at a higher clip than our white counterparts? It is because of institutionalized racism. There is no other explanation. Every single study across the country states that, proves that, and the numbers don't lie. If you're not upset as I am, maybe you should be, because this is the travesty within our field. The travesty within our field, that our people get incarceration as opposed to getting treatment. One of the reasons why I'm sitting in front of you today with this lecture, it is because I got access to treatment. It's not because a judge saved my life or the criminal justice system saved my, none of that is true. The thing that made the difference in my life is recovery, is treatment, is access to people like you who support my recovery. And for those people who go around saying the judge saved my life, I disagree. We don't need to send people to prison in order for them to access treatment or recovery supports. Respectfully, I disagree. And when we say things like that, we collude with a system that is designed to incarcerate us. We need to dismantle that system. So what do we end up with? We end up with dehumanization of our people and a dehumanization of ourselves. Stigma is a fancy word for discrimination. And I began with saying to you that history matters. So we have discriminated against people with substance use disorders, with mental health, when we bring in the intersections of race, sex, gender, every single other intersection, including socioeconomic status, then we see how dehumanization works in process. And we begin to call ourselves and call other people homeless, addicts, frequent flyers, a whole bunch of nasty names, which we should get away from. I am not an addict. My name is Hanar, and I am a person in long-term recovery. I live in the solution, not in the problem. If you decide to call yourself an addict, good for you. But just know that when people in the community hear us say I'm an addict, what they hear is, there's Hanel who stole my car. There's Hanel who broke into my house. There's Hanel who stole drugs on the street. There's Hanel who did X, Y, and Z. I don't want to be a part of adding fuel to that fire. So I live in the solution. When I presented myself earlier today, I said to you, I am a person in long-term recovery. This is what it means for me. This is what it enables me to do. I leave very little room for you to think about me as the person who sold drugs and was engaged in criminal activity, because I haven't done that for a very long time, right? Now, we are more prone in this country to save animals than human beings. Think about it. When you leave today and go out into the community, you see people on every street corner with signs in front of them. And you know what we do? We make sure our doors are locked, our windows are closed. We look away. We might read the sign, but we don't look at people in the face. That is dehumanization in progress. And we need to work against that. If we are serious about developing ROSCs, our ROSCs need to be reflective of non-discriminatory, anti-racist policies that enable people to gain access to services. And we need to talk about that out loud, because if not, we will assume that everything is okay. All we need to do is, for people to understand addiction a little bit more, and we'll be fine. No, I disagree. We need to understand the isms a lot more. More importantly, we need to develop policies and procedures that get us to where we need to go. Strategies and solutions in the short amount of time that I have left. I want to give you some of those, right? And so, our collective power, nuestro poder colectivo, that slide that I brought to you earlier, I want to bring it back. That 23 million people that live in the solution. That is a great resource that we have available to us. And we need to bring into our ROSCs people with lived experience, because they know how to bring people in. It doesn't mean that we are 100% correct on everything that we do. It means that we have a resource that we need to bring in. The biggest explosion in our workforce in recent history has been the hiring of people with lived experience, both in mental health and in substance use disorders. And we need to celebrate that and bring people in, because these folks have that experience of being on the other side. And they have, for the most part, empathy, right? And understanding. But those people need to be diverse. I need to be able to see people like me that on a dime, yo cambio el español, when I switch to Spanish, they can understand me. That when people switch to whatever other language, Haitian Creole, Portuguese, whatever the language is, that we have people who can understand, relate to them, and help them gain access. We need females in the mix. We need males in the mix. We need people who are transgender in the mix. We need people who identify in other ways in terms of gender, and in the non-binaries, right? We need people of all ages, particularly young people, because our field has more older people than young people. So we need to bring people in, is my main point. And those people from the recovery community can help improve and expand those ROSCs in ways that are going to be transformational for our folk and for our communities and for our systems. The next thing is, we need to continue to ground this movement in social justice. Why do I say that? Continue to in social justice, because the recovery movement is grounded in that. Even though some people don't understand that, it is. We are on the backs of, on the shoulders of the movements in this country for civil rights, the movements in this country for other rights, the movements in this country for just treatment of people, expansion of services with dignity and respect. And that can only be done if we continue to engage in advocacy and public policy. Advocacy and public policy. And I understand that in some spaces and places, people hear that and they go, oh, I don't do that. I provide services to people. I don't get involved in politics. Well, guess what? If we continue to have that attitude, the people who are involved in public policy will continue developing public policy without our voices being heard. And what that amounts to are policies and procedures that are not reflective of who we are and what we need and what our people need. And so there is no excuse for not participating. The only excuse is not wanting to, right? And I refuse to be in that camp of saying, I have all of these complaints about what's going on, but I'm not going to do anything else. And again, I know that you're busy people and you provide services to people on a daily basis. But the reality is that we can do both. We can do both. We can provide services and advocate. I call it two A's of advocacy. Lowercase a is the advocacy that I do for the people who are in front of me. Uppercase advocacy is the advocacy that I do on behalf of our field, our system, right? To get services, resources into play so that we can continue doing what we're doing. Now, we need to fund and support a true public health approach. I'm a public health person. If you want to understand what that means, is that we need to fund the entire continuum, multiple strategies over multiple domains. If you believe that your strategy is really good, bring it to the table, but embrace other strategies, right? That's what ROSCs are all about, right? Coming together, multiple strategies over multiple domains, right? Bringing people together along the continuum, prevention, intervention, treatment, and recovery supports. If you have kids, do you want your kids to have a bed when they need it? Or do you want your kids never to need a bed because you did prevention with them? I am a prevention specialist, but I also work in treatment. I see the need for both and I embrace both. I don't go, well, I don't do that because I'm not a prevention specialist. If you work in treatment, you are doing prevention. Here's why. The major risk factor for kids in terms of using substances is having a parent who uses substances. If you work in treatment and you're working with parents who have kids, then you are working on prevention because you're helping that kid reduce that risk factor. That's my push to you to think outside of the box. Prevention, intervention, treatment, and recovery support. Don't stay in the silo. Staying in the silo hurts people. And I know that you don't want to hurt people. So how do we adequately fund that continuum? How do we do that? How do we do that, right? How do we adequately fund it? Look at it, right? We spend more money in prisons and jails in this country than on education. There's a thought. There's a thought. There's billions of dollars there. And then big pharma, the people who are largely responsible for the so-called opioid crisis with pushing opioids, right? And saying these are not addictive. And now they're crying, nope, I'm bankrupt. We're bankrupt. Billions of dollars into the coffers later, all of a sudden they're bankrupt. What happened there? I'm glad that the current administration and the State Department is looking into the Sackler family and those people who gave us oxycodone, Percocets, and a whole bunch of other opioids, and then are saying, we shipped our money offshore, right? Because that's in the literature as well, and we're broke. Yeah, we're broke. We don't have any money, and we filed Chapter 11, right? Bankruptcy. We need to hold some people accountable. And I live for the day where some of those people end up in the same prisons and jails where my people are sitting in now. I live for the day that that happens. Accountability is not just putting money into funds that will then help people with prevention, intervention, treatment, and recovery supports. Accountability is paying for the hundreds of thousands of lives that we've lost. From 1999 to present is over 500,000 people who've died. 500,000 people who've died. Think about that. We need accountability. We need accountability. And I just read the comment, I won't hold my breath for that. Well, that doesn't mean that we should not stop advocating. Just because we think it's not going to happen doesn't mean it won't. Remember that slavery was at one point legal, right? And a whole bunch of other things were legal, and people applauded them and participated in them. So I'm going to push the boundaries, and I'm going to continue to demand that these people be held accountable. Another piece that we need to pay attention to are issues of equity. And so I'll, briefly, because I'm running out of time here, You see equality, 3 people who can't see over the fence to watch the game. You see reality, right? Some people in the ditch, right? And you see the person who didn't need a box to begin with now has 7 boxes. And then you see equity in the middle, right? Equity in the middle. Now everybody can watch the game, hands up in the air, that sort of thing. And I would strongly disagree that that's equity, because it's not. The reality is that equity looks like this, that there is no fence. The fence represents policies and procedures that are in place to keep our people out. Our people don't want to watch the game from on top of boxes. They want to participate fully in society and be treated with dignity and respect. And that is called liberation. So when we think about equity, we need to be revolutionary in thinking about it in out of the box ways, right? All of those things that I talked about regarding mass incarceration, the fence represents policies and procedures and those deliberate policies that I talked about. I want to say to you that there's more than one pathway of recovery. More than one pathway of recovery. 23 million people in recovery in the US, about 20% of them did it through MAT-MAR. Why are we pushing medication-assisted treatment on everybody? Faith and recovery works. 12-step works. Rational recovery, smart recovery, celebrate recovery, holistic approaches, meditation, yoga, what have you, all of those things work. Are they for everybody? No. And so what we need to do is put a menu of options in front of people, have them select what would work best for them, and we work with them on that. Harm reduction works. We need to get out of our own way in telling people that they need to do things the way that I want them to do them. Because if we don't, we will continue to chase our tails and blame people for the misery in which they live. And that's what we do now. We are pushing one pathway on people and saying, if you don't do it this way, then you are not going to ever get better. And when they have a reoccurrence or a relapse, we blame them. We need to take a page out of the restaurants in this country that put a menu in front of us when we go to eat and they ask us, what do we want? Not you're having hot dogs whether you like it or not. So we need to shift in mentality, right? All of those pathways work. We need criminal justice reform, and we also need restorative justice, because many of us still have stuff on our criminal offender records that should not be there, like marijuana charges, right? All of those things. And then we need a workforce that is more reflective of the population. I wish I would have had more time to continue to share with you, but I don't. Thank you very much. And thank you for all the work that you're doing on the ground.
Dr. Hernandez, I know there are hands going up everywhere. If you see this chat, I know you look at this chat, but thank you so much. I know that people have questions for you and want to reach out to you, and you are just so good. And folks, if you didn't get to see Hanar speak at National Recovery Month on September 9th, go into the Faces and Voices of Recovery website and you can see the recording there. And then again, remember, this recording is going to be available to you. So you can go back through this and really digest what he is saying. My heart is full. You know, I don't know about all of you, but we've had a lot of different perspectives today. And today is, you know, National Recovery Month. It's for everyone, right? Every person, every individual, and every family. And he just nailed it. So anyway, thank you so much. Thank you. And we look forward to seeing you again soon.
Thank you.
Yeah, thank you. Thank you so much. So guys, right now, we would have definitely checked the chat, put your name in, organization. I keep repeating that over and over. We want to connect with you. So you've heard a lot, right? You've gotten a lot of information, and our folks presenting today are passionate about what they do. And that's why they are in the roles that they're in. And so we know we need everybody at the table. Look around your table. Do you have everyone at that table? You know, it's one thing to get those people at the table, but it's another thing to keep these folks engaged, right? So our next presenter is going to give you strategies to do just that. I am telling you, she can have anyone in a room and everybody feels that they're a part of the conversation and their voice is heard. So next up, Jessica Hulsey is the founder and CEO of Addiction Policy Forum, a national nonprofit dedicated to elevating awareness around substance use disorders and helping patients and their families in crisis. APF works to end the stigma surrounding addiction while translating science and providing services in all 50 states. She has more than 25 years experience in the field of prevention, treatment, and policy solutions to address substance use disorders. Along with many of her advisory board roles, she also serves on the National Advisory Council on Drug Abuse and is a board member for the Federal DEA Educational Foundation. As I shared earlier, she lives in Maryland in Montgomery County and is the mom to 3 beautiful boys, Connor, Jack, and Tyler. Ladies and gentlemen, please welcome my friend, Jessica Hulsey.
Thank you, Carol. Thank you so much for having me today. It's such a pleasure and an honor to be a part of this. I so enjoyed the presentation from Dr. Hernandez, and it's just wonderful to be with you all. So I'm going to try to share my slide deck. Where do I do that?
Jessica, there should be a share button right in the middle at the bottom of your screen.
Okay. It's not highlighted,
Um,
but I'm fixing it. There we go.
Do you want us to pull them up? Therese, do you have them available that we can put Jess's slides up? So,
Or Haley on my team, I think, is on, and she could share the slide deck. Or if you have them, Carol.
yeah.
Otherwise, I think it's
I
making
can-
me close WebEx and reopen, and I could be back in 5 minutes and do it myself, but I don't want to be disruptive.
Sure. Yep. Let me just pull them up. Hang on.
Hang on, folks.
You
Thanks,
know,
Jess.
it's not a virtual meeting unless you have at least 1 or 2 technical snags. It's sort of our Zoom
Yeah.
life these days, right?
Look, I have myself all, once you hear Hanar speak, you're like, oh, so excited. That's how I actually feel when I hear you speak, Jess. So just
That's
FYI.
Well, while we're figuring out the slide deck, I'll just go a little bit into sort of my background, and sort of I'm really excited to talk about meaningful stakeholder engagement because it's such an important part about how we do this work. And it's tricky, right? And if we have great ideas and great passion, but we can't get the right folks to the table and can't keep them there, then we don't have as much impact. So it's exciting to be at this meeting with you this month to celebrate National Recovery Month. Many of you know if we've been at meetings together, but I'm a product of recovery. I'm what comes next. I'm the daughter of my parents who struggled with opioid use disorder. My mom was in recovery for a number of years, thanks to a combination of MAT and a really good recovery support program for Native Americans, which was sort of that dynamic duo that really worked for her. And I do this work as a love letter to my mom and to both my parents, and are really committed and have spent my career trying to help patients and families. I kind of describe it as when addiction hits your family, it's sort of like you get hit and run over by a Mack truck, and there's no one there to help you pick up the pieces or sort through what to do or how to manage this. So what happens if we fundamentally change what that experience is? What happens if, like you heard from Dr. Hernandez, what happens if we connect people to what they need instead of pushing it off to other people? And I love some of the metaphors and examples that Dr. Hernandez gave, particularly that menu option. We do a lot of work on patient-led and research and bringing our patients and families to the table with our researchers and scientists. And it's not one thing. Treatment and recovery, long-term stable recovery for addiction is multidimensional. And we've found from some of our research that it's not one thing or another. It's actually on average 5 different interventions, services, or things that people need to get healthy and well and stable. And sort of that definition of recovery is so important. It's vitality, it's wellness, it's returning to your life vibrantly. It's not just abstinence or survival. So I think when we collectively use our voice to change and advocate for some of those pieces, that's where some of the beauty lies in this work. I started APF about 6 or 7 years ago now, but I have been in this field since I was 15. Working for a prevention organization, and I've done work in the policy sphere and treatment, and then really wanted to create a space where patients and families were included at that national table. We do a lot of direct services. We do a lot focusing on the stigma around addiction and how to change it. We need to do more. Language is a good first step, but there is much more that we need to be invested in to truly change the stereotypes, the labeling, the prejudice, and the discrimination that is involved in the stigma around addiction. So those are some of the main focus areas for us. So next slide. So talking about meaningful stakeholder engagement, this is not just sort of examples from my work at Addiction Policy Forum. I kind of wanted to bring some sort of lessons learned from things that I've done maybe well and things that I've done not well, and the lessons that we can sort of all glean from how do we bring these sort of vibrant communities together to advocate at the local level for our patients and families, to advocate for our field, to push for change in this sphere. And whether that's in your own community, your city, your county, throughout Maryland, nationwide, like how do we sort of advance this and have real meaningful engagement with our stakeholders and grow what that means. So a couple of things I wanted to go over is like knowing your why, sort of setting up the pieces and the building blocks that you need to engage with folks. What I call creating your orchestra. I've been very, very passionate about criminal justice reform in my career. My mom went to prison as a result of her substance use disorder and spent 2 years in a state prison system. My dad was in and out of jail for most of his life, and I lost him when he was 48 years old. So seeing sort of the difficulty of not being connected to treatment, but instead incarceration is made the CJ reform piece really important. And that orchestra piece really has sort of come through and how we've had some success in some measures when it comes to prisoner reentry, sentencing, and other policy reform in that criminal justice space. Knowing your audience, running efficient meetings. That this might feel like a very boring topic, but we can lose people engaging with us if we don't figure out how to keep them engaged for the long haul. And then I want to talk about gratitude. That's such a common topic in the rooms and in other spaces with mental health or addiction treatment, but I think it needs to be more present and prevalent in how we talk about engaging with our advocacy networks, that gratitude piece. And then I want to talk about frequency of engagement and sort of what that looks like for the long haul. So next slide. So I love Simon Sinek. You've probably seen him in some of his videos, like on Facebook or around the channels or the interwebs. He has a book about Know Your Why or Start With Why. And I really think it's important because we can't convince people to join our cause or to stay with us if we can't clearly and succinctly communicate who we are, why we're doing this work, what it means to us, and then the things that we do, whether they're the priorities, they're the objectives, the programs that we play, we can bring them into the fold there. But if they don't know the why, if we don't know why we care about this, why we do this work, what our vision is, and that's like the big picture. This is what I want the world to look like in 10 years versus our mission. This is what I do every day. This is what organizes my organization, my work that I do in advocacy, my own network or coalition. So as I was introduced to you today and we started out, what have I done? I've shared with you my why so that you know why I do this. I do this work as a daughter, right? This is why I'm committed to this issue. This is why I started the nonprofit. That's why I've been doing this work. Next year will be my, I think my 30th year anniversary in the field, which is fun and crazy all at the same time. But I've shared that with you because I want you to know my why. I want for you to listen to me for an hour to talk about meaningful stakeholder engagement. I'm not going to start with the strategies or how to run a good meeting or what coalition building looks like and retention and sustainability. I want to start with you understanding why I do this work, so you can sort of feel engagement with me and knowing what my mission and what my fire is in my belly, right? What's my rocket fuel that keeps me going? So the other piece that happens so often, particularly in the addiction field, is we can get really complicated with our why, right? So I had my annual physical earlier this week, right? And we all got our masks on and whatnot, but I'm seeing a new doctor. Oh, what do you do for work? Well, he doesn't really want to listen to me go on for 19 minutes about my multi-pronged, multi-year strategy about how we fix the addiction crisis and help families and patients in crisis, build evidence-based care. I've got to give him maybe not even my 2-minute elevator speech. He needs to know my 30-second version of this. So sometimes it might seem simple or maybe oversimplified, but getting down who we are, why we do the work, and what we do, our purpose in that 30-second and then that 100-second dosage of what we do and why is a really important exercise and system so that to go through to make sure that we have our ducks in a row. That's simple, like what? So tell me what you do. Well, I run a nonprofit that helps patients and families struggling with addiction. That's my 15-second version of it, right? Oh, why do you do this work? I lost my parents to addiction, and I've been doing this since I was 15. It's my calling and my love letter to my mom. Going through those processes to make sure we can talk about something that's so passionate and critical and part of who we are. But with that passion, sometimes we can overcomplicate the things that we say and the things that we do to express the vision, the mission, the programs that we run, and at the core of it, the why. To share sort of some of that, to make sure your commitment to this issue and the why behind it all comes through front and center with the work that you do. And one of the quotes from Simon that I love is that we are drawn to leaders and organizations that are good at communicating what they believe. Their ability to make us feel like we belong, to make us feel special, safe, and not alone is part of what gives them the ability to inspire us, right? So sharing that why you care about this, and then following it, the what you do and how comes after your coalition, your network, your stakeholders that you are organizing. They can feel that. They walk away from every meeting and engagement with you, understanding what you believe and why you care about this. So next slide. So the other piece that I always like to chat about is some companies have done a much better job than even my 15-second, sort of like kid carpool or patient exam room, or you're at a barbecue back when we could all go to barbecues when someone asks you what you do. But the why or your mission or who you are, sort of these value propositions that we hear from companies like TED, Spread Ideas, Oxfam, A Just World Without Poverty, Alzheimer's Association, A World Without Alzheimer's. And then Nike is to bring inspiration and innovation to every athlete in the world. When we take a page out of some of the most recognizable and clear and succinct brands like Nike, like TED Talks, we can learn how to advance how we talk about and spread our mission, our vision, our goals, and the why that we do this work, who we are, the values, the belief systems, and the why that we do this. So a little bit on how we've approached this at Addiction Policy Forum on the next slide is our vision. So that's what do I want this world to look like when my kids are grown and having kids of their own, and when I become a grandma, is I want to eliminate addiction as a major health problem, right? That's the big picture. The mission is leading the fight against the devastating consequences of addiction and helping patients, families, and communities impacted by the disease. So when we can simplify and communicate why we care about this, what our vision is, what do you want the world to look like for the next generation, right? Planting that tree, what does that shade look like that we plant today in the work that we do? And then that mission, this is a statement, one succinct sentence that can organize and explain the work that your organization, that you do in your day-to-day advocacy, the work that you do every single day. Addressing the deadly consequences, leading the fight, helping patients and families in crisis. This is a succinct way to explain all of the programs and services that we currently have underway at Addiction Policy Forum. The vision gives you a peek at our why. Next slide. So the other part after you know your why, and many of you might be like full on out of the gates on this. You have your elevator speech going, you know how to explain why you do what you do, to what objectives, what's the vision, the mission, and then you can explain your programs. And then we get into this sort of stakeholder engagement, right? We want to bring more people into this world with us. We want more people to buy into our vision of the world, to join us in the advocacy and the work that it takes to achieve that vision by investing in the mission that we're setting forth, with the work that we're doing every single day. So how do you do that, right? How do you build a coalition? How do you keep them engaged? How do you have diversity in the types of stakeholders that engage in this and build relationships that are long lasting? So I use this orchestra metaphor. And this is a little bit of sort of the policy work that I've done. I was a Capitol Hill staffer for a number of years, and then I ran a government affairs shop for a state association, really working on criminal justice reform. I worked on a bill called the Second Chance Act, from sort of like the idea and sort of the seed of it to getting it signed into law, which took 6 years. It's now had, I think, over $700 million appropriated and put out to communities and states to improve prisoner reentry, to improve services and what happens, not just to reduce recidivism, but to help that transition from prison and jail to the community. And so much of that population is like my mom, are struggling with substance use disorders, and we need to improve what that looks like, what that process, that experience is. So I'm very proud of the work that I did, but it was a haul, right? I think I started this work in 2002, and when you like Googled or went to search for reentry, you got like pictures of these little like space capsules reentering the atmosphere. It was this very new concept and very sort of debatable, or lots of feelings and emotions. There wasn't consensus, it was partisan. So how do we get there? So the orchestra is really kind of one of the concepts that I think came out of that work over 6 years until now. We're coming on, 20 years ago that we started doing that work. And the beauty about the orchestra, to think of this, like in the addiction field, it may be simpler to get, let's say, one type of stakeholder to be a part of your orchestra, right? If you're advocating in your county, in your city, and you have recovery services, peer services, maybe you have healthcare providers and treatment providers who are engaged, and you feel like, oh, I have my coalition or my stakeholder group. They are committed, we have this. But the reality is that we need to have like all the different sections in our community, all sort of working off of that sheet music from sort of this music that we're trying to create, right? So for some areas or lanes, you're going to need to have law enforcement that is engaged in your work. You may need to have your faith community that's engaged. You may have the business community, to have employers, insurers, payers engaged. If you don't have all your sections with those seats filled, then you have just a string section, right? You might just have brass, but you don't have the orchestra in place to really play that symphony. So taking a moment to consider and evaluate, do I have an orchestra? Do I need to shore up and have strengthen one of the sections? Do I have a cross section of all of the sectors in my community that really need to feel to be a part of this and to be engaged meaningfully, so they can give feedback and I can have more success? This has been important because in my example of working on the Second Chance Act, I needed different parts to play louder for different barriers or issues. We had major challenges at different sort of crossroads with a member sort of standing in the way, or different organizations not wanting to sort of see this go. So one orchestra, and figuring out how to sort of bring them to the table and help us get over those concerns, barriers, challenges, to really advocate on behalf of that mission, right? And again, we're very clear. What's the vision? We want to improve services for all individuals reentering communities from prison and jail. Our mission is to focus on a piece of legislation that creates more resources and brings this issue to light as a priority for states, for counties, for cities, for policymakers, for all of the decision makers that are a part of this. So once we brought people into why we do this, what our vision and our mission is, when you have your orchestra, they can be there to help you advance your goals and the world that you're trying to enact by making sure that you have representation from your whole community. So when you take a moment to be like, oh, you know, I'm a little light on the faith leader side, and we want them to be a part of what, you know, recovery-oriented systems of care looks like. My recovery advocacy work, I want to make sure our business leaders are engaged. We don't have criminal justice leaders. We don't have enough individuals with lived experience. Do we have families engaged and the family systems represented on our board, on our stakeholder board, on our council, on the work that we do in our network? So I think an assessment and looking at what you have and what you want to build, and the previous exercise helps you with that pitch, right? It helps you bring new people into this collaborative way of approaching how we build networks and how we are efficient and successful in our advocacy for this issue. Next slide. So I already mentioned this, but sections of the orchestra, faith community to community services, healthcare, policymakers. There are many more sectors and sections of your orchestra that you might want to make sure are built out. That's really about you customizing that to your community, but knowing that, and even if you don't have people ready in a certain sector, it is such good practice and learning on how we do our jobs better, even when we have a sector or a leader that may not be ready at this moment, that may not sort of see eye to eye with us on a certain issue. They might have concerns about X, Y, or Z, or don't know much about our issue, or may have misconceptions and misinformation that they've heard. That is useful information, right? We can build stronger advocacy systems when we take time to listen to people who have concerns and may be reluctant. And when we win them over, we are executing the skills to be better advocates for our cause, right? So all of these sectors are worth investing, even ones that may not be ready to come to the table today. Next slide. So know your audience. I would say that there is so much richness in our field and in our issue. When we take the time to tailor and to work with that stakeholder crew that we put together to tailor what you need to say to bring new people, you get really good at that. So you have your like elevator pitch, but then you figure out what nuances you need to add to that pitch to each of those sectors, right? You might have a very different way of bringing a pastor or priest or someone who's a faith leader from the faith community to the table with you. This is an issue that your parishioners struggle with. We know that you care about the people you serve, and there are resources and new science and new tools and services that are available in our county that you can provide to your community when you get involved with the work that we're doing, right? To employers, you might have a pitch about lost revenue in sort of absentee days and losing workforce, and this being an issue that causes distraction and disruptions within their workforce systems, that they know that their employees are struggling with this issue. They might have troubles and difficulties with recruitment and retention because of SUD. We need you at the table to give us intel and guidance, right? And this is a pitch that isn't about just corporate funders or we need your money or we need sponsorships of this. Making this about a why and a mission and a change that is meaningful to them and what their why is, right? So understanding the why of your stakeholders so you can see a meeting of minds in your work area is really what we have to do to build these meaningful coalitions. Next slide. So I know this sounds like maybe the most boring component of a little training, But I got to tell you, you can lose a lot of people that you do this work, you know your why, you know your mission. You're looking at your orchestra. You've got great people you want to retain, and you have new sections of your orchestra that you're building. You figure out their why, you figure out how you match up, you go pitch them, you bring them in. You can lose them pretty quickly if you have a not well-run meeting or you're not invested here. So I'm going to nerd out a little bit on this, on the dorky portion of today's presentation, because it's really important. One of my rules, and something that I reinforce with our team here at APF, is that you need at a minimum to spend twice as much time prepping for the meeting as the meeting is itself. So today I'm spending an hour with you, but this is a multi-hour conference and training. So estimate, as the leader and sort of the, if you've got the baton on organizing meetings for your coalition or network, you should spend about twice as much time. And that's not necessarily for a big event like this or something else, even for a regular monthly or weekly check-in. On my Monday afternoon check-in with my team at APF, I spend twice as much time prepping for it as I expect my team to be on a call with me virtually, right? So it's being deliberate about the agenda, making sure that your network is involved in every single element of the agenda, making sure it's interactive. The quickest way that we've lost people is by making them feel that they wasted time or there wasn't meaningful engagement. Like I gave something, that I left something, I had input, I gave feedback, that I can see that I have had influence and opportunities to engage and be useful. Like this helps me with my own personal why, because I didn't just come to a meeting. I came to a convening with your organization, and I felt like I was listened to. I felt that my input influenced the cause and the issue that we are working on together. And I saw the effects of my participation in today's meeting and beyond. So looking through to make sure interactive. Teeing that up, I call it kind of the cricket section, when never once when have I run a meeting where I don't have at least 5 sidebar conversations to let folks know, Carol, when we get to this section, I'm going to call on you first, and I really want to know what your feedback is in this issue area. So if you could think about that. So that's one of the calls, one of the prep emails, one of the things I'm going to do prior to a meeting ever beginning, because what I'm doing is I'm inserting into my relationship with my board members, my council members, my network, my state chapters, that I want you to be a part of this. I don't want to do this without you. And your input and feedback is going to help me with my programs and what happens, not just at this meeting, but beyond. So simple things, whether it's a poll during the middle of your virtual meeting, whether you have people teed up and then you track it to make sure that over the course of your year of your meetings, everyone at the table has had a pre-call from you to feel engaged and they're important and they've been asked to provide direct input. So it has to be meaningful, not just, oh, I did a checklist, everyone has been on the agenda or the annotated agenda, but you do follow up. You let people know progress on where you are with their implementation. A couple examples of this is, I don't know if any of you all have seen some of the work that we've done in the translating the science. One of my big pet peeves as a family member is, like, I'm not a neuroscientist. I was an English lit major. I have no idea what some of these words and concepts and terms are that some of the researchers or doctors will throw out. I want to understand how I can save my loved one's life, how I can get them connected to treatment, how I can understand what evidence-based treatment even looks like, and it's understandable. It isn't that I have cognitive issues or I'm not smart, it's that I'm in crisis myself because I'm worried about someone I love, right? And so in that moment, we need to translate to the family member. We need to translate to the individual who is looking for help. So we work on translating that. So we've done a series of cartoons. You might have seen our hijacker videos sort of explaining in metaphors and in cartoon animated graphics, taking the neuroscience of addiction. This is a health condition, affects the brain, you can treat it, you can recover from it, your brain can heal, all of these things from these researchers. And I live right down the street from NIDA. So I had all these series of sessions with neuroscientists. But here's the thing about meaningful stakeholder engagement. I didn't just develop that myself, and after talking to Dr. Volkoff and Dr. Compton and all these like great leaders over at NIDA, we went and sat down with our stakeholders. We had, this is what we learned and what we put together. What do you think? They liked some of it. They didn't like some of it. They gave us feedback about colors and imagery and how we display and explain certain things. They gave us feedback on words that didn't work for them. We learned from them that the word receptor felt really scary and they didn't really understand what that meant. So can you explain the effects of the brain without some of these words that we feel are a little inaccessible for some of our patients and families? So and then we got that feedback and then we showed them our work. Did we do a good job? Is there other feedback? So when you have a feedback loop with your stakeholders, when you ask them meaningful questions with the intent to take their feedback to improve the work that you do every day, and then you close the loop with them to show them what you did and to see if you did a good job. It might be feedback for your priorities for your county. It might be feedback on a program or an awareness campaign or what you're doing for National Recovery Month. But ask them with the intent and the actual follow through to show them that their input matters and take action on the items that you receive from your whole network. That is about meaningful engagement. And that's how you can make your meetings not just run efficiently, but your meetings become something where people feel that they are valued. They should leave every meeting feel like this was worth my time because this organization values my input and participation. And I see the effects of my input in the work that they do. Next slide. I have one other like random example of this. So one of our other projects that we do, we call it the Stop Overdose campaign, which sort of tells the story. Like right now, last year, looking at the data from overdose deaths, we sort of saw this head-on collision between addiction. It wasn't just opioids. We're looking at adulterants like fentanyl in all of our street drug supplies. We had 95,000 overdose deaths. Isolation, a terrible terrible exacerbator of the addiction crisis. So that's 255 people we've lost today. So our Stop Overdose campaign allows us to tell the stories of our families. It's moms and dads and daughters like me who've lost someone that they care about to addiction. It's not just overdose stories, but largely overdose loss. And when we relaunched this, and Haley Tenney on the Addiction Policy Forum team, she leads this project for us. And every year when we sort of have new numbers that come from the CDC or we relaunch this, we don't do it on our own. I put mock-ups together, Haley does some graphic design, and we give it back to our families. And if they don't like it, we don't use it. One year, they really wanted it to be green, about this, like the color scheme to be green and about rebirth and to feel more hopeful and more happy. And so we scrapped this entire thing because the feedback from the people you lead, they have to see that you listen and implement it. It is an important part of the relationship that you're building with those that you want to be on your team. So the next piece of this is about gratitude. I think this is an important part of communication and engagement with your stakeholders. This is a great quote from William Covey about the 7 habits of highly effective people, that we want to be validated and feel appreciated. So taking the time for that. Every year we do a Pillar of Excellence series, our award winners, to recognize people in our network and in the field that do amazing work. Take time to say thank yous, to do the personal calls. Sometimes it's a text message or a simple call or sending a note. On my team, we did a series for a bit that I would just have a candy bar for 1 or 2 staff members at each meeting that we had as a thank you. But we need to remember to add gratitude, like the teams that we build. Like, it is an honor to be able to bring people together to work on this issue. It's an honor that I'm grateful for every day. So every person who either works with us directly or works on a board or is a volunteer, it's my job to make sure that everyone feels the gratitude that we feel continuously, right? So making time for that. What does that look like? You don't have to spend money on it. You don't need to go buy a bunch of Crunch and Twix or Snickers bars. It's a lovely, simple thing to do. But just taking that time and thinking through in their shoes, have I adequately built a plan to make sure everyone I work with on a daily, monthly, yearly basis, they feel gratitude from me for giving of their time, resources, and talents to do this work. It's an important part of, I think, getting people to follow you and to advocate on behalf of a mission or an organization that sometimes we forget. We feel so much passion. People should join us because we all feel this way. But service needs to be, I think, honored and validated, and people get so much more mileage for reminding them that we're grateful for their contributions. Next slide. So this is the other piece. This is a little bit of a fundraising strategy that I am not a great fundraiser, I'm going to admit. I don't really ask for people for money very often. And I have, like, my board ends up having to, like, nudge me because I'd rather be, like, building a new cartoon about some piece of science that I feel we have inadequately shared with our community, or some stigma intervention I'm working on. But when we take some of those lessons from our sort of development fundraising partners, we know that on average, you should be connecting with a potential donor 7 times before you ask them for money again. So let's say these are your donor pod. Let's say folks that gave you $100 this year. Before you ask them at your annual solicitation or maybe a phone call bank next year, you should do 7 things. They get an update, they get a little postcard in the mail, they get a call saying thank you, they get a little lapel pin if they donate $500. There's all these strategies. These are like large donor strategies and many examples. I've just never had one of those, but that's what the literature tells us. You need to have 7 touches, 7 moments before you ask them for something again. I have tried, instead of this being a fundraising strategy, to make this about stakeholder engagement strategy. Before we have a big thing that comes up, I need people to help me with a research project. We need to do X, Y, or Z on a new awareness campaign. I want to feel that I connected 7 separate, distinct times with my network before our next big ticket project or awareness campaign or piece comes in. Sometimes being included in some of that can be one of the 7 things themselves, but thinking through in that year-long time outside of the projects that we do, I'm going to remind you I'm grateful for you. I'm going to give you an update to make you feel included. I'm going to give you an opportunity for input to make what I do better. I'm going to do that 7 times in the 1-year relationship that we have on an annual basis. That is the objective that I have in the work that we do. Carol seems to think that I've done a good job with that. Sometimes I get some good feedback. We have a really good retention rate of our volunteers and our leaders in the community. So I'm hoping, fingers crossed, that it's working. But also this means that I know I'm keeping myself accountable, that it is an honor to get to work with people. And it's my commitment and my duty to make sure that I make them feel engaged and appreciated. And it's not a one-off. It's actually 7 times that I'm going to be thoughtfully thinking through what that process looks like. The next slide. All right. I think I got through it with a few minutes to spare. Is there questions or pieces that I can go over and provide more feedback on?
That was so good. How about any questions? Anybody will open up a mic if you want to jump on and ask Jess any questions. And Jess, while people, do you mind mentioning the National Leadership Conference while you're on the phone?
Sure.
Or while you're on? I want to say phone, but.
We are having our National Leadership Conference virtually on November 4th and 5th. I'm very excited because we have a kind of an all-star lineup. So Dr. Nora Volkoff, director of NIDA, and Dr. George Koob, who's the director of NIAAA, will both be joining us to give a sort of an overview of where we stand on the research and science side from both of their institutes at the NIH. We also have Sean Ferns from the DEA, who's going to share sort of an update on sort of the threat assessment and what they're learning and seeing on the ground from DEA, which is, spoiler alert, a lot of fentanyl and everything and a lot of cause for concern. We're also having Dr. Nadine Burke-Harris, who's the Surgeon General of California, who's done amazing work on addressing childhood trauma and adverse childhood experiences. We need to go upstream and address intergenerational trauma and intergenerational substance use disorder and make sure I have a high ACEs score. I'm a kid who went to foster care because of my parents' substance use disorder. I think I turned out okay. I had a lot of interventions that started at 8 when I was in the court system, and no child is unsavable. So we will have a focus and a panel with Dr. Burke-Harris and other experts to really talk about that issue. We have a few Zoom sessions on the advocacy side. We are working on the Equal Act, which is the Cory Booker, Dick Durbin bill to fix the disparity between powder cocaine and crack cocaine, which has had a tremendous inequitable application, particularly among our Black communities, of much more incarceration, longer sentences that has been sort of racially disparate. So we're very excited that we'll have a session there. We're also going to do a session on stigma and some of the legislation that's in Congress right now, including a bill that would rename NIDA, the National Institute on Drug Abuse. I don't say the A word, abuse, and saying substance abuse or substance abuse disorder is inaccurate. This is a substance use disorder. Abuse is a criminal justice term like elder abuse, animal abuse, child abuse. Substance use disorder is a health condition that affects 20 million Americans today, with 23 million Americans in recovery from substance use disorder. And we want to change the language that we use to house it appropriately in the health sphere instead of the criminal justice sphere. So we have a session on that. And then we have awards that we're giving to a top researcher, a top public health official, a top advocate of the year, an amazing clinician at West Virginia University named Dr. Jim Barry, who does such good treatment of substance use disorders with such care, and really sort of raising up the physicians and doctors who do a lot of care for our patients is really important to us. So it's free, so join us if you have time on the 4th and the 5th. We're really excited about the conference and coming together. It's our first time we've done this virtually, so knock on wood, it's going to go well.
Oh, thank you. Thank you for sharing that, because it really, if anybody's ever been to that conference, and several of you on this call have been, you know how good and how well prepared it is. So, as was this presentation, by the way, and I can't thank you enough for doing this, because one of the things that I was hearing with a lot of the different ROSC was that, you know, what's the framework? How do we get, we get people to the table, but, you know, how do we keep them? And so that presentation, that overview was fantastic. So, and again, I'm going to share these slides and people will get to see that recording as well. So thank you again, Jess. Thank you, thank you, thank you.
You're very welcome. This is the first one for me, so I'm glad you liked it.
I know you said that. I'm just like, I can't believe it, because you have so many different folks at your table and you're able to navigate, you know, you navigate all that. So, you know, I'm a fan, so I'll just say that. And I use you as a model for, you know, when I try to run meetings and try to live up to how you do it. So thank you so much. Thank you for that. So folks, I'm going to ask that right now, I hope you're all doing okay. How are you making out? Everybody's good? Okay. You've been checking the chat, put your information in there. This is the time that we want to hear from you. Now, we only have a bit of time to hear from a couple of the different ROSC, because as I said earlier, there's some really good work being done. So we want to hear some of that, right? And we won't get to everybody because, and I'm just going to say it like I did it. I had a couple people in mind that I knew were doing some things and wanted to ask them to share. So if you have anything going on with your ROSC that you want to get that word out about, please put that in the chat or just email me separately and I'll make sure I'll help you any way you need to build your ROSC. We need to help one another. We can't be in silos and think this county does that, that county does that. No, we all need to work together. This is not a competition, right? So anyway, I'll get off my soapbox here for now. But at this point, it is, let me see, if you all don't mind, we'd love to see your faces. So if you are interested and want to turn on your camera, just keep your sound muted unless, you know, we're calling on you. That would be great. We would love to see your faces. So let's see, is Laura Sheffield, Kelly Marquardt on the call from Washington County? Are you guys on the call?
Yes,
Hi,
ma'am.
Carol.
Oh, hey. Would you guys mind sharing a little bit about what you're doing with Washington County and any kind of challenges you might have had with that, with your ROSC, and how you maneuvered around those, how you got folks involved, and any kind of events that you have coming up? Because I know you're doing some really cool things that are different. So.
Yes,
Take it away.
absolutely, Carol. First of all, we appreciate the time for us to be able to speak, you know, in this platform. And first, I really want to say it's been a pleasure, you know, to work with you, Carol. And I just personally just want to thank you because you have been such a tremendous help with us in restructuring our ROSC in our county. So my name is Laura Sheffield Bishop. I'm a social work supervisor at the Washington County Health Department, Division of Behavioral Health Services, and I co-chair the Washington County ROSC. Joining me today is my fellow co-chair, Kelly Marquardt, Certified Peer Recovery Specialist. So I remember our first Washington County ROSC meeting where Kelly and I invited numerous community stakeholders in hopes that they would show. However, we found that some of our community partners did not show, or some of the partners actually questioned why they needed to be part of that group because they really felt like it just didn't pertain to them, even though Kelly and I knew that it really did. So really, Kelly and I concluded we couldn't be the only county really struggling to restructure the ROSC. And we really felt at that time it was important just to reach out across counties and to see what other ROSC groups were doing. So through Kelly's numerous calls, we did have the pleasure of connecting with Carol, who really did, again, provide us some really great guidance in discussing what was working in her county at that time. It did take us many months to figure out what would work in our community, but we did find using the virtual platform was very helpful in reaching more of our community stakeholders. We did later decide to develop a subcommittee that would focus on the development of a vision and mission statement of ROSC, how to frame ROSC in our county, and the issues that we have experienced specifically for resources. When we were structuring our subcommittee, we wanted to make sure that it was diverse and really represented various parts of the recovering community. Some of the members that are part of our subcommittee now is our mayor, local addiction authority. We have substance use providers, mental health providers, prevention specialists, peer recovery specialists. I'm going to use quotes here, but like consumers or persons served within the system, and other non-providers such as like representatives from our faith community. We have found that the subcommittee is very helpful in brainstorming community events that we want to host and to divide tasks to each subcommittee member. And it just really helps to streamline that planning process for what we want to do. Most recently, our subcommittee planned the first annual recovery cookout to celebrate recovery and to help members in the community to feel connected. And I really must say, we are so excited to say this was very successful. We had such a great turnout and we plan to do this yearly. In addition to our subcommittee, ROSC has become really an informational hub in getting needed information and resources out to our community stakeholders and partners. So we do offer bi-monthly ROSC meetings where we host, different speakers and just provide educational topics. So as an example, most recently in September, we had several wonderful speakers that helped us celebrate the 32nd anniversary of National Recovery Month. And we did this on Facebook Live, so our whole community could review the remarks of our distinguished group of speakers. So we are very pleased to announce that as of today, we have over 500 views, and many people have commented that this meeting really instilled hope and even excitement in knowing what our community is doing in regards to behavioral health recovery. Furthermore, I just wanted to note too, for the month of October, Washington County ROSC is actually going to be partnering with two programs, Washington Goes Purple and Baby and Me Tobacco Free program, to raise awareness of neonatal abstinence syndrome. So to do this, we're asking our stakeholders and our community members to wear pearls and bow ties to help us start a conversation about reducing health-related stigma among all moms and babies, so that they can get the support and care that they need. We also had pearl and bow tie onesies made with the ROSC logo that we did create that will be provided to babies born at our local hospital in supporting of this awareness campaign as well. We also plan to get our local media involved that will highlight this campaign, but also highlight what ROSC does. We were also able to get our very first billboards posted in our community. And what we had was a statement that said, end behavioral health stigma and save lives. We did this billboard because one of the ROSC goals that we identified was stigma and how that really impacts individuals and how they access care. So we know it's important to build a village in the recovery community, and we're really striving to do that in Washington County. So I'm going to turn it over to Kelly, who's going to just discuss this other part of ROSC, which is called ROSC Recovers Group.
Thank you. Hi, I'm Kelly Marcourt, Certified Peer Recovery Specialist. And as you know, I'm the co-chair of Washington County ROSC with Laura. And as she was saying, we've had many challenges when restructuring ROSC in our county. Laura really focused on the needs of the providers, and I focused on the needs of the consumer. When looking at the ROSC definition, the word consumer was used at one point in time. Most recently, when we were continuing to do our research on ROSC, some of the language did change to person served or individual. We recognized the word consumer, person served, or even the word patient can be stigmatizing, and felt that this language needed to be changed. So I developed the ROSC Recovers group that consists of individuals seeking or in long-term recovery. When we think of ROSC, we really need to address the entire system, because the behavioral health system consists of not only the providers, organizations, and local officials, etc. It really does focus on the individuals accessing the behavioral health resources. We really wanted to give a voice to our recovering community so that we could bridge the gap in the system. So the ROSC Recovers group was responsible, like Laura said, for the first annual recovery cookout that ROSC sponsored, because individuals voiced that they wanted to feel connected with other community members. The cookout was extended to all of our community, and we were excited that many of our local officials attended with the goal of connecting further with those who are a part of the recovering community. I am continuing to meet with this specific group to plan further community events that are geared to recovery. Again, Carol, we want to thank you for the opportunity for allowing Laura and I to share what we are doing with your help. And I really hope that this can be helpful to other ROSC groups. And please feel free to reach out to us, as we are always looking for new connections. So thank y'all for your time.
Hi,
Thank you.
it's Linda. Can I ask a question?
Sure. Who was that? Was that Linda?
I'm sorry, I just muted myself again.
Hey, Linda. Yeah, sure. I just want to say, guys, Kelly's, I'm just going to say it like it is. Kelly's got a terrible migraine, so I can't even believe she was able to get on today. So that's why you're not seeing her lovely face.
Thank you.
So feel better, okay, Kelly? All right, Lynn, what's that question you got?
No, I was just wondering, from from Baltimore County's perspective, we just heard of a lot of different kind of ROSCs. I just wondered how you all are funded. I know some are nonprofit and others, I just don't know where the funding is coming from across the board.
And Linda, that's a really great question. So at least with us here in Washington County, you know, because we're based within the health department, but we really strongly rely on our community partnerships. So, so we have some people at the table that are like 501(c)(3)s, and then some people in our group can go and elicit donations. So like for our pearls and bow ties, we had a local business that actually knitted bow ties, and they're going to drop them off. So it's really like when we look at funding, that is an issue, but we really have tried to just develop those partnerships to really make it happen. And what we have found is that a lot of people, at least in our community, are really dedicated to that, to try to make whatever we need happen. And so like our cookout, for instance, like everything was really covered. Like we would go to our subcommittee group, and like somebody like a mental health provider would be like, oh, I got you, like we'll get drinks, or I'll reach out to so-and-so. So it was really just that collaborative process, and just figuring out like what is it that we needed and how do we get there. And again, we really relied heavily on our subcommittee to kind of make those connections too for us.
What about the billboard? Like I would think that those kind of things, like we had at one point Baltimore County had a fairly strong ROSC, and then we kind of need to reboot after COVID. But that the big projects seem to be the things that, because I think a lot of the people want to get a tax write-off. So unless we went through another 501(c)(3), you know, sometimes our donations were not were not great. So how did you fund something like the billboard?
Again, even for like the billboard, like we just used a lot of our subcommittee and the resources that we had. And so like, again, we have like a specific like partner with us. And Kelly, you might remind me, but like the Justice Advocates. And so again, they're a 501(c)(3). And so sometimes again, like they could elicit the donations. And again, sometimes like we would go and like ask people like, hey, this is ROSC, this is important, you know, this is what we're looking to do. And some places were like, yeah, we got you, like we'll do it for free. And then, you know, that's how we started that. You know, really just trying to make that relationship was what we have really honestly have found to be really key to a lot of the movement that we're doing.
But Laura, doesn't Vicki also allocate some funding for you?
I believe she does. So like, and again, Linda, like I don't know all the ends of that, but with Vicki Sterling, she's our local addiction authority, and is also within the behavioral health. So she's my direct supervisor. So she would have more, probably could answer more of that. But sometimes I believe like there is probably like a minimum funding like through, you know, like through the health departments. But again, I don't know what that looks like for every county. But, you know, again, even then it's like, it's only not that, it's really not that much. So again, it's really, what I have found is just the partnerships is really critical to make this really happen. Because historically, and I know it's time, but historically our ROSC was like 4 people.
Right.
And so we, like when Kelly and I took over ROSC, we were like, okay, I think it's been said probably multiple times today, but it was like, what's a ROSC? Like what does ROSC do? How do we streamline resources? And that's kind of like where we started, because when we were doing ROSC groups or meetings, I should say, people would come in, we would have like providers, and they were like, oh, we do substance use services or mental health, you know, and it was like, we shared all these wonderful resources, but it never got outside of the ROSC group. And so Kelly and I would always scratch our head and say, like, how do we take this outside this group? Like, this is great information, but it's not really helping us. And so that's why we were reaching out to kind of restructure, because if we're talking about the behavioral health system and how to really transform that, you got to share that information. And so the model that we kind of came up after just kind of, you know, kind of experimenting really in a way, we found it really does work. And even with like our community campaigns, it's not really focused a lot, I would say, like on funding. It's more of just having ROSC meetings and getting information out, sending constant emails out to our stakeholders of what's happening. Again, trying to partner with like some of the bigger campaigns like in our county. So one of them is like Washington Goes Purple. And again, just kind of using things that are kind of already implemented, but really, again, building that relationship. And that's kind of, again, where we're at in Washington County. We're like in a phase 1, I call it, where we're just building these relationships so it can benefit us later when we're continuing to really do ROSC.
Thank you,
Sounds
Laura.
like you
Thank
guys
you,
have done
thank you,
great.
thank you. Thank you,
Thanks,
and
Laura.
Kelly, Linda, thank you for that question.
Yes, thank
So
you, Linda.
I'm trying not to cut people off. I don't want to be rude, but I do want to make sure, Teresa, you're up. And
Sure,
Teresa's going to
yeah.
next. Go ahead, Teresa.
I see Joel Trainer and Jennifer Wheeler from Recovery Anne Arundel, and we'd love to hear from you all next. We know that you have a very kind of unique and very well-run ROSC group. So if you'd like to share anything with the group, we would really appreciate that.
Thank you, Teresa. My name is Angel Trainer. I'm the Executive Director of Serenity Sisters, and we run recovery homes here in Annapolis. We are 501c3. My first time at a ROSC meeting was in 2009. As I said, I'm a person in long-term recovery, but then I was still fairly new to my recovery process, and I had a boss at Anne Arundel Community College that said, I need you to go to this meeting for me. And I knew that I had to go. I walked into the room. There were 15 people sitting in the room. It was at the health department. I see Heather Eshelman is on the call. Heather was taking notes for George Phillips, and I saw all of these people at the table, and I knew them from a very different lifestyle. I knew them. I was a JID number, or I was a client, and I was like, oh my gosh. And I sat down and I listened. And within the first couple of meetings, I knew that recovery-oriented systems of care was something that I absolutely would buy into, because as a prior consumer, I knew that it took many different organizations and people to get me to the point where I entered into a life of recovery. So for the first 6 months, I just sat in those meetings and I didn't say a word. Because I was afraid that they would recognize me. And then as they started to recognize me, and some of those people are no longer with us. So George Phillips is no longer with us. Greg Wright, who was my addictions counselor when I was at the lovely Anne Arundel County Detention Center, he's no longer with us. But they started to recognize me, and they gave value to my voice as somebody who had entered into recovery. And I thank God for those people every day, because they helped me to find my voice. And, going along, I realized that it was this organization, this ROSC, was run by our health department. And they were new, and they were just kind of getting things together. And they didn't do a whole lot, but they had some great ideas. And within the first year, we came up with our first annual, what has now become the 9th annual, we just had it, Recovery Walk. About 5 years into the process, I'm saying, and I was listening to Jessica, and it's all about the engagement. And at about 5 years of the Recovery Walk, I'm like, wait, how can we expect people to understand who we are and what we do if we only do one event a year? And as Angel usually does, I stuck my foot in my mouth, and I got put onto an events committee. And that has just the process throughout the over 10 years that I've sat on the ROSC, which is now Recovery Anne Arundel. The health department saw value in putting this organization into the hands of a nonprofit. Before it came under the umbrella of Serenity Sisters, it was with another nonprofit. So when the health department came to me and asked me if I would be willing to oversee this and be the coordinator of the ROSC, it was a huge honor for me. By that time, gosh, some of the things that we had started to do, we had the annual Recovery Walk. We started an event, Recovery Over Dinner, where we invited the community out, because our ROSC is strong. Pre-COVID, we were every month 40 to 50 providers and community members would come to our monthly meetings. So we did recovery over dinner, the recovery walk. We've done some plays. We've gotten community engagement that way. And then I started giving thought to how do we bring law enforcement? How do we get law enforcement and get them into the fold and bring them on board? Because, you know, they're not, the people in recovery and law enforcement, not so much would people think that we get along. And we started Hoops for Hope. So it's a very lively basketball game between the Anne Arundel County Police Department and a group of young men in recovery. It's very well received. Everybody loves the event. Through all of that, there's so many things, and I want to pass some things on to Jennifer, but through all of this, Recovery Anne Arundel applied for and won one of 15 slots with the now defunct Facing Addiction for a Communities Project. And so we were one of 15 across the United States, and we got a group together to really do some digging into the community to see what the community needed. And gosh, what came out of that? I think the two things. We were supposed to come up with one goal. Anne Arundel County, we're either very aggressive or overachievers. I like to think overachievers. And we came up with two goals. The first goal was to develop a recovery resource guide, which would go out into the community. And to date, we have distributed about 18,000. They're accordion folders, they're pocket size, and it's just full of great information. The other goal was a community recovery center, and I really thought that one was aggressive because I didn't know how we were going to do it. And I'll leave that part. I'll leave the recovery center to Jennifer. You know, it's all about the collaborations and the community partners that we have. You know, Carol Boyer, I miss you. We need to have lunch and kind of regroup. You know, Carol helped us get our International Overdose Awareness Day event up off the ground. We're at year 5 for that. And we just reach into the community because we want to help. We just want to help. I want to see individuals come from living a life that they're not very happy about and come into a life of recovery and feel like they belong. Because much like myself at those first few meetings, I did not feel like I belonged. I didn't have a voice. I didn't know where it was. And I feel like in part, my job is to help those individuals find their voice. So I think our biggest accomplishment so far is the Recovery Community Center. I have visited recovery community centers from Connecticut to Georgia to Florida, looking at different models, wondering how we can bring that model right here into Anne Arundel County or Annapolis. I'm Annapolis based. And how can we get that here? About 3 years ago, I sat down with a group of people because I do nothing by myself. I would be nothing without my team. And part of that team is Jennifer. And we sat down and we wrote a grant for the state to be able to bring the Recovery Community Center right here. So Jennifer, I would like to turn it over to you and give you the Recovery Community Center piece. And then we can answer questions. Thank you. Thank you, Carol. Thank you, Teresa.
You're welcome. Thank you. And I just want to make sure, guys, if you have questions, again, put it in the chat box. We're running a little bit behind, but I definitely want Jennifer to jump in there. And we've got about 3 minutes, and then SAMHSA is with us. So, well, Dr. Jean Bennett. So, okay, Jen, take it away.
Uh-oh.
Are you on? Did you unmute yourself?
Good afternoon, everybody. And thank you for giving us a couple minutes to speak. And we are very excited at Recovery Anne Arundel to have acquired and settled on our building last Friday afternoon in Annapolis, a Recovery Resource Center. And so We've been well received by the community, received the support of the health department. I even truly believe that the seller was an instrumental part in allowing us to purchase the building that we recently acquired. And it will be a resource center where peer recovery specialists, prevention coalitions, crisis response, the opportunity to work with workforce development, to just come get guidance if you're new in recovery and need direction. There will be people on staff there throughout the week to offer guidance to the people that come in seeking help in recovery. So it's just a one-stop shop. We look to partner with the DSS and CPS and legal aid. And again, like I said, workforce development will be a big one because we'll have a computer room where people can come work on their resumes, learn about interview skills, and how to apply for jobs and find out where the job fairs are. And there will just be that public opportunity. There'll be a room that'll be available for them to use a phone if they don't have a phone, but they need to make calls and conduct calls privately or with the guidance of a peer to help them in receiving the services that they're looking for. And we hope to offer wellness opportunities. It has a nice big room, so maybe we can have a yoga, meditation, art. Has a nice backyard. We'll put a couple picnic tables back there so that like Washington County, maybe we can have our own recovery picnic at our own facility. So it'll be nice to be able to have that. So it's been about 3 years in the works, I believe. And so it's a huge accomplishment for us. And we hope to open sometime in the first quarter of 2022. We'll keep you all posted.
My gosh, I was just going to ask you, when is it? Because you've been talking about it, and I'm like, oh, are they open yet? Are they open yet?
Yeah. So we still have a lot of work to do inside, and just dressing it up and making it look professional and warm and inviting and respectful to the people coming into starting a new phase in their life.
So it's fantastic. I know I speak on behalf of everybody on the call, but kudos to you guys. And thank you for sharing that. So,
yes.
Dr. Bennett, I look at the registration and I see Jean Bennett from SAMHSA. And I'm like, wait a minute. So, Dr. Bennett, if you're on the call, we would love to have you say a few words from SAMHSA. And by the way, folks, SAMHSA is Substance Abuse and Mental Health Services Administration. So the H is silent because some people say SAMHSA, and so Sam, take out that H, SAMHSA. Dr. Bennett is actually the Region 3 administrator. And Dr. Bennett, correct me if I'm wrong. I think you cover Pennsylvania, West Virginia, DC, Maryland, and Delaware. Is that correct?
That's exactly right.
Okay. So thank you so much. Oh, there you are. Thank you so much for joining us, and take it away.
So it's really great to be here. I was able to listen to all but 40 minutes of your conference today, and I was just blown away by every single speaker. And it's such an honor to be here. I had to jump off for a few minutes to go to a surprise retirement for a recovery champion, Roland Lamb, who ran the Department of Behavioral Health in Intellectual Disability Services, Office of Addiction Services, right before I came on here. So I feel like I need to channel a little bit of the Roland Lamb champion and all the things we learned from each other, which so much of that happened today. So, we heard the leader view and addiction medicine doctor view from Dr. Jones this morning. We heard the researcher view and lived experience view from Dr. Best. And Dr. Hernandez was so inspiring about be a disruptor. How can you be a disruptor and help get things done? And then Jessica brought us right back down to earth. Like, here's how you do it. Here's my examples of how you can do it. Break it down into little pieces and get things done. And so, I could talk a lot about things that happen in the region with recovery and the recovery data, peers, and Medicaid summit that we had on September 1st and September 8th. But I want to pose to you a call to action. And what I think would be really exciting is if everyone could take what you've learned today and think about what is the one idea you heard about today that you would like to implement. Something within your sphere of control that's practical that you could implement. And I'd like you to put that in the chat or let the organizers know or email me. So what idea do you want to implement? What collaborators would you need to do it? What resources would you need to do it? And what is your first next step within 2 weeks? So think about, look at your calendar, 2 weeks from now, the first next step for implementing your idea related to what you learned at this conference. If that happens, your chance of actually getting that done will be better. And there's never been more resources and funding than ever before. I've been in this job for 10 years. You know, I'm connected to the passion of folks with lived experience because my brother died at 18 with alcohol use disorder and substance use disorder on my first day in the Navy, and it just made a permanent imprint on my life. And you know, that is why we're all here today. So I think you've got great information, but now what are you going to do with it? And you know, if I had to compare all the states in the country that I know about and what they're doing with recovery, I mean, Maryland is just so impressive. It just blows me away. And, you know, the leadership on this call and the community members on this call and the individuals with lived experience in recovery on this call are just, it's just overwhelming and you can probably hear the emotion in my voice, to think about the possibilities of what you can each accomplish if you start your own idea and collaborate with others you've met on this call or that you now know from this conference that you need to seek out. So I could go on, but I'll tell you, there are some incredible folks at the state level that have approached me about moving recovery forward using data and figuring out a way to make recovery-oriented systems of care a part of everything we do systematically, sustainably, and you know, in the most person-centered and respectful way possible. So those are my closing remarks. Carol, thank you so much for having me, and I feel really honored that I had the chance to learn from everybody here today, and I look forward to continuing to work with anyone who's interested. I'm very easy to find.
Oh, Dr. Bennett, thank you so much. This is such a great way to end this call, to have, I call it SAMHSA the mothership, you know, so it's fantastic. And we're so grateful that, you know, you see that need and we need, and you said it perfectly, collaborations, right? So, and you tearing up, that's how we all are on this call. It's heartfelt.
Yeah.
Everybody's doing it because we want to do it. We know if we can save one life, everything was worth it. So thank you from all of us. So at this point, folks, I just want to let you know that we want to hear from you. So what we're going to do is, because this meeting was originally set up to be really geared towards the behavioral health directors for each county in the city, and then also the ROSC co-chairs, and then we changed it. So the survey that we're going to send out, there's two. One will be just for the different counties and Baltimore City and their ROSC leadership, so the directors of behavioral health and then the ROSC co-chairs. So because we want to gather some information, send it up to BHA to see what it is you're doing, how we can improve on some things. You know, are you a 501c3? Are you, is your county involved? Is your agent, are your agencies and elected officials involved? What does that all look like? So you'll get back. And by the way, thank you to Linda Bryant from Baltimore County, because Linda is actually doing the minutes for today's meeting, and she actually helped with the content for that survey. And others that are on the call, you'll also get a survey just to know what we could do better because we're going to do this again next year, and hopefully in person. And so again, you will get a survey as well. Teresa, would you like to go ahead and do some of our thank yous?
Yes, I would love to. So before we go, we'd like to thank our speakers, Robin Ricard, Dr. Aliya Jones, Dr. David Best, Dr. Hanar Hernandez, and Dr. Jean Bennett, as well as Jessica Hulsey. Our sponsors, Peter D'Souza from Hope House Treatment Centers and Tom Carl from R1 Recovery. You were all instrumental in making this event possible, so thank you so much. And also, I would be remiss not to thank Carol for all of the time and endless energy that you've put into planning today. I know pivoting to virtual wasn't what we planned or what we wanted, but these are the times. So thank you for this event and everything you've done for the ROSC in general. It's been great to work with you on this.
Thank you, Teresa. You guys, I said to Teresa and Michael, will you ever want to work with me again? Because they know how, how my brain works. It's like all over the place, but we need to be organized to get things done. And I got to say, the Opioid Operational Command Center, I've said it from day one, they are an amazing group to work with. So if your county, your ROSC isn't involved with them in some capacity, you need to get involved. Help them with those town halls, right? Get the word out, because the ROSC is supposed to be in the community. And so that's how we're going to do it. A ROSC can link the county to the community and vice versa, right? Connect the community to the county or to the city, to those folks who are making decisions on your health based on, what data is out there. So thank you to Robin Ricard. Thank you to Marianne Gibson. Thank you to Brandy Kahn from the OOCC. Michael, you rock. You're so great with the communication. So thank you so much. Can't say it enough. Teresa, right back at you. I hope, when I asked you about doing this, it seems like forever ago, and you didn't flinch, you didn't bat an eye, and you guys you made it happen. So from the bottom of my heart, thank you for that, because I wanted everybody to kind of feel some kind of cohesiveness, because one county says one thing, one says another. And if we help each other, and I truly mean this, if we were to reach out across those county lines and help one another, can you imagine what we could do? We say recovery is for everyone. Well, let's do it. Let's really do that. Let's make it about every person, every family, and every community. So I would like to also thank Laura over at Washington County, because she, anybody knows me knows about my slide skills are, they don't exist. So thank you, Laura, for doing those slides. And thank all of you. Thank all of you, because you took time. This was a long day, and we had an extra speaker in there that I know you were not disappointed with, Hanar. So thank you so much for taking time out of your day. And what I'd like to leave you with, Dr. Best said it about human connection, the power of human connection. So take your right hand. It might be the left on one side, but put that over your left shoulder. Go ahead and do that right now. And I'm hoping that Haley over at Addiction Policy Forum is going to get capture a shot of this. Take your left hand and put it over your right shoulder. Give yourself a big squeeze. There's nothing like a hug, right? And we're all missing that right now. I know I am. So I just, that power of touch and the power of listening, because that's all people really want to do. They just want to be heard. So I leave you with that. Again, thank you to everyone. And don't forget, surveys are going to be coming. And I'll leave you with this. And I kind of lead meetings at all that I do all the time with this. Gandhi once said, you find yourself when you lose yourself in service to others. So may we all continue on that journey of finding ourselves while in service to others. I'm so honored that all of you showed up today. Apologies to anyone who showed up at the site. We had a couple people show up at the site, but again, thank you, thank you, thank you. Have a great weekend. Don't forget, Recovery Month's not over yet. We still have 6 days, so make sure you're sharing your events, and thank you so much. Bravo to all of you. Teresa, you want to say anything? Michael, anything? We're out. Okay, thank you guys. We're